Hey two, take one two, test, test. Okay. Hey, test, microphone check, line check. This is a handheld, spare handheld microphone. We are testing the line over the streaming, I think. Yeah, hey two. No, they will be hey two. Do you think they are the same level? If I keep the level equal,
Yeah, of course it's the same
hey, 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 hey.
Okay, we're going to get started. So, welcome to the Advanced Curriculum for Multiple Sclerosis. I'm Fred Lublin from the MS Center at Mount Sinai in New York City, and we're delighted to be able to put on this course, and we're doing it thanks to the cooperation from our colleagues at the ECF, specifically Xavier Montalban and Hans-Peter Hartung, and your board for allowing us to join this program. We've been giving this course in the US over the past 10 years. And we've done it because there's few areas of medicine that have been as dynamic and evolving as the area of multiple sclerosis and multiple sclerosis therapeutics, hence the need for all of us and our colleagues and practitioners around the world for educational opportunities. One of the things that we decided when we were planning this course was to set up a broad educational course that then would be a nice lead-in to the more targeted approach that will start tomorrow from the ECF meeting. Part of this I want to thank, in addition to the folks at Academic CME, which is Chelsea Simmons and Patrick Hayes, who are around here somewhere. We have folks, we are live streaming this, so there will be folks on the internet, and I'll tell you a bit more about that. And we want to thank Sanofi for their support, as mentioned here, through an independent educational grant. This is our program, which we'll go through and hopefully try our best to stay on time. Please scan this QR code. It will allow you to submit questions. You can also go to the two microphones when we have the question and answer session, but if you want to submit questions, I'll be monitoring them from a laptop up here, and also the people online will be able to send in questions or comments or such. When you scan that code, the first thing you'll see is a pre-test, which you could take at your leisure. It's for the educational people. We won't be showing the results. We don't know who you are, so you won't be individually graded. Unless you wish to be, in which case see me afterwards. Give you a minute to scan that. Okay, and the disclosures, there's nothing relevant to say here. Individuals will give theirs, but none that are of concern for this particular program. And that's it, we'll get started. So our first speaker is Professor Amit Bar-Or, from the University of Pennsylvania, where he's the Melissa and Paul Anderson President's Distinguished Professor, Chief of the Multiple Sclerosis Division, Director of the Center for Neuroinflammation and Neurotherapeutics, and a research scientist at the Children's Hospital. So, welcome, Amit.
Well, good afternoon, everybody. Buongiorno. A delight to be here. Thanks to Fred for involving me and, in fact, entrusting me in this initial presentation. I will show my disclosures here briefly and jump straight into the objectives and outlines. And again, as an introductory talk, the first goal is really to provide a framework and some insights into the involving conceptual framework of MS pathophysiology, and very much with a goal of trying to set the stage for some of the subsequent talks that you'll be hearing about, especially in this particular session with a series of presentations, but subsequently as well. And in that context, I'll try to emphasize some of the aspects that we've learned over the years with respect to the cellular immunology that plays out in the periphery and we think is very much involved in driving relapsing disease biology in MS, and then some emerging concepts in terms of mechanisms that are playing out within the central nervous system, and that's what we refer to as compartmentalized processes that we think involve both inflammatory and degenerative mechanisms as the basis of the more complex, non-relapsing progressive disease biology, and try to provide some insights into the evolving thinking about the relationship between relapsing biology and non-relapsing progressive biology. And so, of course, from the standpoint of who develops multiple sclerosis versus who does not, we think of this as a complex human immune-mediated condition based on the implication of multiple genes interacting with multiple environmental factors that result in some state in the periphery of an abnormal immune regulation and trafficking of activated cells to a target organ, leading to injury in the case of MS, of course, the central nervous system. And the genome-wide association studies have now taught us over the last years over 230 variants each of which contributing a tiny bit to risk, not a single one of which is by definition abnormal. People who do not have MS or any other neurological or autoimmune condition can have some of these, but more of them creates a susceptibility that needs then to have a range of environmental interactions. Each of the EBV, vitamin D, smoking, adiposity, and microbiome have been important aspects of environmental exposures that almost certainly play on the genetic susceptibility. And so we think of the original sin as an immunologist of what was the very beginning, the chicken or the egg, if you like, and as far as the development of MS, and its initial activity, we think really that the original sin relates to some abnormality of peripheral immune regulation, inappropriate control of activated pro-inflammatory cells, and their trafficking into the CNS, so the relapse biology. But I want to contrast that with the most recent chapter of genetics, which makes the point that if you then ask, within multiple sclerosis, are there genetic variants that associate with more or less rapid progression? Those seem to be more CNS or neurobiology-based, glial cells in particular, as opposed to the peripheral immune cells. And here I just want to make the point that we need to keep an open mind that possibly initiating mechanisms of a disease are not identical to the ones that propagate it, whether propagated as relapsing biology or non-relapsing progressive biology. So those are some really general comments on those features that contribute to the development of MS, but maybe different ones that contribute to its evolution. And EBV is a good example. Again, for this talk, I won't have time to go into details, perhaps in the discussion, but EBV has now been very strongly implicated as a necessary yet insufficient risk factor without which it seems you cannot get MS. At the same time, the questions that arise, and more data now supporting its potential important role in relapse biology, and the very intriguing prospect that when it's in the central nervous system, it may be a driver also of non-relapsing progressive disease, so more to follow on that. And the general framework, which is summarized in this very simplified model, recognizes that the immune cells that are largely in the periphery interact, get activated, traffic into the target organ, and mediate their effect on the tissue. And in the textbooks still, some refer to this as a T-cell mediated disease, but happily less and less. It's not that T-cells are not important, but we've clearly learned that it's about interactions between different cells. T-cells are important, B-cells are important, almost certainly myeloid cells as well. Again, in those peripheral aspects of cellular immune interactions underlying relapsing disease biology, and we've had historically pretty good imaging markers of new focal inflammatory activity to capture that process, whether it's clinically evident or present under the surface, as it is to a significant extent, especially in the earlier years of the disease. And then we have the CNS compartmentalization, including immune cells from the periphery that set up shop there, interact with one another and with brain cells, and the brain cells themselves responding to and contributing to an environment that we think is very important in driving non-relapsing progressive disease. And it's really in recent years, and you'll hear more, that we've begun to get some handle on in vivo imaging measures that may capture at least part of the non-relapsing progressive disease. Again, most of it is happening under the surface without us appreciating it, and it is almost certainly starting years, if not decades, before we begin to appreciate this in the clinic. So this concept or term of transitional MS, we probably should revisit and try to avoid using that. It's not a magical day of transition from relapsing to progressive. Both of these biologies are playing out at the same time in the same individuals, both mostly under the surface, overlapping by decades. Let's focus and become a little bit more granular on the periphery, emphasizing some of these peripheral cellular interactions. At the core is the capacity, the potential of the immune system to see particular antigens within a target organ, such as the CNS. We know that important regulators of autoimmunity involve striking appropriate balance between effector and regulatory cells, best studied on the T-cell side, and here's some of the nomenclature of the multiple different functionally distinct T-cell subsets, both pro-activating or inflammatory and down-regulatory or relatively acquiescing limbs of the T-cell response, and striking the right balance between them has implications on the control of autoimmunity. T-cells don't work in isolation, and myeloid cells represent one class of antigen-presenting cells. A T-cell needs to see its antigen presented by an antigen-presenting cell. We've known over many years that myeloid cells can shape T-cell functional responses and vice versa. So a bidirectional arrow reflecting important interactions between these different types of cell populations. B cells traditionally were thought to be sitting around and waiting to get T-cell help, hence the name of T helper cells, to tell them to turn into antibody-producing cells. We now know very clearly from the MS field with targeting B cells selectively and its impressive and somewhat surprising impact initially on limiting relapse biology, that B cells are important in relapsing disease activity, but that benefit occurs without changing the face of the abnormal antibodies in the CNS. So B cells are important, but their importance, at least for relapsing disease, appears to primarily be related to non-antibody dependent aspects of the B cells. And this cartoon shows that B cells also can be thought of as having subpopulations of functionally distinct groupings, here based on different cytokines, the different balance that they may strike in terms of releasing pro versus anti-inflammatory cytokines. And we've learned, again, not just in MS, but in autoimmune diseases in general, that B cells and their subpopulations can influence autoimmunity, and they can absolutely talk back both to T cells and to myeloid cells, and hence bidirectional arrows between all these different subtypes of cells and their subpopulations. So complicated, but the cartoon depiction captures this as multiple interactions that we need in the normal state, and when some of these interactions aren't happening properly, it may spill over into an autoimmune disease like multiple sclerosis. So clearly myeloid T-cell interactions, B-cell T-cell interactions, and B-cell myeloid interactions. And we can think of multiple aspects of these different interactions that have been identified over the years on average as being abnormal in MS patients versus controls, and there's heterogeneity there. So different individuals, based on their gene-environment interactions, are likely to have more or less of a problem with their T cells, their B cells, their myeloid cells, but in combination for that individual, it's enough to spill over into an immune-mediated disease. You might say, well, why does anti-CD20 seem to work well across broad populations? Who cares about heterogeneity? That's because B cells seem to play a rather important role, and you remove them, and they are not driving other aspects of the disease. And in that context, there's a lot of interest, as I said, and we can talk more about how Epstein-Barr virus may be involved in the disease. And I think very plausibly, it is about EBV's potential role in the context of B-cell, T-cell interactions in particular that would be the basis for why EBV is involved in the initial development of the disease and quite possibly in propagating relapsing disease biology. So that was really a rather quick overview of some of the peripheral immune cellular interactions that we think are relevant, not just in health, but in disease, including in multiple sclerosis, and responsible for the focal, perivascular, inflammatory consequences of relapsing disease biology. Let's transition into the CNS compartment to talk a little bit about the evolving thinking with respect to those processes that are thought to be contributing to non-relapsing progressive disease biology. And this is from Tanya Kuhlmann's very elegant, relatively recent Lancet Neurology review. And I show this just because it makes the important point that the pathologic substrates that we think are relevant for non-relapsing progressive disease biology are complex. And they involve multiple different subcompartments within the CNS, and we are beginning to get a sense of what those are and need to learn more about how we may be able to target them therapeutically. But as has been very helpful for us historically, we can use the consequences of intervening with a therapy to learn more about the disease itself. And many people in the audience, this is one of their passions. And I expect that we will, with data that we've seen and data that will be emerging over the next months, be continuing to shape our sense of biologies that are relevant in therapeutics that may target them in the context of non-relapsing progressive disease. And at least two of the subcompartments that we now think in terms of the pathology are relevant for non-relapsing progressive disease include these chronic active lesions, sometimes called active inactive lesions. And the point here is that I already mentioned that focal perivascular lesions develop as part of relapse biology. But then it turns out that a subset of them have this second life. And the second life involves an ongoing chronic inflammatory process that is likely contributing to ongoing injury. The presence of those chronic active lesions has been well correlated with worse trajectories of progressive disease. And we now have, as you'll hear more about, in terms of paramagnetic rim lesions and slowly expanding lesion measures that capture at least some of this aspect contributing to non-relapsing progressive disease. The other subcompartment where non-relapsing progressive injury seems to be playing out importantly involves the subpial aspect of the cortex. So these are ribbons of demyelination that are subjacent to the cortex, and I'll talk a little bit more about them in a moment, as well as the deep gray structures like the thalamus and the caudate, especially those sides that are abutting the CSF interface. And so I'll try to give some updates in terms of our thinking in terms of both these processes, the chronic active lesions and then the subpial and deep gray injury. So very elegant work by Martina Absinta and Danny Reich, which I think is one of the pivotal papers in terms of providing insights about the potential mechanisms involved in chronic active lesions, is based on this elegant single-cell analysis, nuc-seq analysis, of cells identified within chronic active lesions of MS pathology. And the point here, and it's reflected in the title, is that when they look at the different molecular expression profiles of the different cells that are involved in a chronic active lesion, first they can find cells from the periphery, such as T cells, B cells, myeloid cells, and they can find CNS cells, including microglia and astrocytes. And the profile of molecules expressed by these different cells very strongly suggests that they're talking to one another, because they reflect receptors and corresponding ligands on the different cells. And this is what has contributed to the concept that this is a condition that involves interactions, if not networks of immune cells and brain cells that are participating in this process. How much of the abnormal features are an attempted response to the injury, maybe even an attempted repair, versus mediating the pathology, we don't fully understand, and that's very important for us to try to better understand and sort out, and I'll talk a little bit more about that in subsequent slides. The most recent iteration of looking at the subset of lesions that can be seen on imaging with a paramagnetic rim, which is thought to reflect microglia, probably, more so than macrophage, microglia that have iron in them. That's what provides them with the paramagnetic properties that can be captured as a hypo-intense rim on the typical MRI approaches to look at them, the susceptibility type imaging, is the recognition that some of these rim lesions have a particularly broad rim. And so this, again, is a very elegant and relatively recent paper that includes both the pathologic characterization, the MRI characterization, and some PET imaging characterization, making the point that when you have a broad-rimmed rim lesion, it appears to be the baddest of chronic active lesions. It's associated with the worst trajectories of progressive disease. So important for us to understand that there's heterogeneity across lesions. We want to know more about why a lesion in the same brain may or may not become a paramagnetic rim lesion or chronic active lesion. And of course, if there are features that can identify or predict, ideally, the more aggressive ones, we would like to know. That would be helpful, of course, for enriching for clinical trials and for treatment discussions as treatments that can target these biologies become available. And apparently playing a very key role in the context of the chronic active lesion is the chronically activated microglia. And I emphasize chronically activated because, of course, microglia are present for a lot of very important reasons listed on the left in terms of normal brain function, homeostasis, etc. But they need to be able to get activated when there's a cause, for instance, an infection or trauma, and then they need to become quiescent again. If they become activated and stay chronically activated, this is something that has been enabling people to identify, in fact, across diseases, states of chronic microglial activation that have been referred to as DAMs, disease-associated microglia, not just unique to multiple sclerosis, but present clearly in multiple sclerosis. And single-cell analyses of these microglia identify functional profiles that make it pretty inviting to think of those as potentially damaging, as opposed to necessarily protective, although I think there's still important heterogeneity for us to figure out. And this chronic microglial activation is present in multiple different CNS subcompartments. We started here talking about the chronic active lesions, where they clearly appear to be present in the rim, but true for other aspects of the CNS. And they don't work alone. This is just a slide from a review, not from the MS field, but recognizing very important crosstalk between microglia and astrocytes. So just analogous to what I was saying in terms of peripheral immune cell interactions. Here you have brain cells interacting, shaping each other's responses. And of course, both microglia and astrocytes play very important roles, for instance, in the homeostasis and regulation of oligodendrocyte precursor cell and oligodendrocyte biology, not to mention neuronal biology. So important interactions, and impacting any one of these may have consequences on the others. This in particular is underscoring the axis between different brain cells. So those are all features recognized to be present in chronic active lesions. I want to say a couple of words about this other aspect of CNS pathology that is also strongly associated with worse trajectories of progression when there's more of it, and may or may not be mediated by the exact mechanisms of chronic active lesions. And the reason that it's not obviously the same is that we recognize in the subpial regions, again, the area of the cortex that is just underneath the pia meninges, adjacent to the CNF and the glia limitans, is that in areas where there are immune cell collections in the meninges, and an example on the right shows what's described as a B-cell rich immune cell collection in the meninges, you're more likely to see a more extensive demyelinating lesion in the superficial cortex next to where the immune cells are sitting in the meninges. They're not touching the cortex, right? So any role for them would be through soluble products. But the pattern of the injury in the cortex, which on the right-hand side is showing % reduction of neurons on the y-axis. So bigger numbers means more lost neurons. And on the x-axis are the different layers of the cortex. Superficial layer 1 by the pia meninges, all the way down to deep layer 6. And the solid lines reflect neuronal losses occurring in cortex next to where there are immune cell collections. And the lower, lighter trajectories are neuronal losses in areas in the same brains that are not next to immune cell collections in the meninges. So where you have immune cell collections in the meninges in the same brain, you're much more likely to have demyelination with substantial 50% plus neuronal loss in the most superficial layers, and a microglial activation pattern that is also graded, with the greatest activation most superficially, less and less as you move deeply. And the same pattern of pathology, demyelination and a graded injury and microglial activation, is present in those areas of the deep gray that are also next to the CSF. And this has invited the attractive hypothesis that perhaps something is being released or present within the CSF, maybe released by immune cells in these immune cell collections, that may be mediating through some toxic mechanisms a slow ongoing process of injury, might call it inflammatory degeneration, is a coin I like to use because it's a form of degeneration of tissue, but it is because there's an immune cell or an immune response contributing to it, as opposed to degenerative mechanisms that may not be related. And that's, I'd like to emphasize, as another aspect of the complexities of progressive disease biology. Here, I'm looking at sites and potential mechanisms, and I've already mentioned the chronic active lesions in the subpial cortex in deep gray, and already identified inflammatory mechanisms where immune cells in the meninges and subependyma and immune CNS interactions, as well as microglia and astrocytic activation may be relevant. But here's a list of multiple other potential mechanisms that have been invoked over the years and continue to be revisited that may also play important roles in non-relapsing progressive disease. And these include problems with supply and demand from an energy perspective, mitochondrial problems, ion channel problems when there's enough injury and distribution of channels or redistribution, you have greater, again, demands over the supply. There are substances that are normally cleared effectively to not be toxic, but when not cleared, when there's injury, for instance, to astrocytes, you may get glutamate increasing, oxygen radicals released by activated microglia. The very interesting data with Katerina Akosoglu, in particular about thrombin and fibrinogen, which is clearly neurotoxic. And then, as more injury happens, you get uncoupling of these networks, increasing demise, loss of compensatory mechanisms. And as we think of these, I want to make the point that we are talking more and more about compartmentalization, but we need to remember that there still is bidirectional interaction between the periphery and the CNS. So that there is compartmentalized inflammation and degeneration doesn't mean it's entirely independent from the periphery. And indeed, very nice papers talking about the gut-brain axis of bilateral movement, as well as the very recent insights into dural immunology, skull-based immunology, meningeal and choroidal interfaces, where there's more and more emerging data recognizing normal processes involve these subcompartments, and very interesting questions as to how they may be relevant to an inflammatory condition like MS. I'm going to finish by just making very quick comments about a couple of slides. This is a data set with Xavier Montalban as a senior author, a nice review that I think makes the point that in addition to the gene-environment interactions, there's epigenetics, meaning the same person's genes may play out very differently biologically over time as they are shaped by other environmental exposures. Some of them are listed there, and that all of this that I've described, and these two processes of peripherally mediated relapse biology and CNS compartmentalized inflammation and degeneration overlap, do not transition magically, but overlap likely by decades, with the presence of, for instance, paramagnetic rim lesions, even in the context of the earliest that we see someone who's correctly diagnosed with multiple sclerosis, even in the RIS, radiologically isolated context that turns out to be MS, and that these overlaps make it difficult for us to know what's happening under the surface. And what we'd like to be able to do, and you'll hear more during the meeting, is to identify biological measures that can capture subclinically what's happening, how much contribution in this person sitting in front of you, relapse biology versus progressive biology, and that will play very importantly, I think, into our treatment discussions and decisions. And of course, over time, all of this is superimposed on aging of the immune system, aging of the brain, senescence, as well as this concept of inflammaging. Immune senescence we mostly think of as decreased immune capacity, which is why elderly have more risks of infection and cancer. But inflammaging actually is increased low-level inflammation that appears to be pathologic, is invoked in cardiovascular or vascular disease, and almost certainly is something that if people with MS have more of it or less of it, will influence their trajectories of clinical progression. So I hope I've given you in this sort of blitz talk some sense of evolving themes pathophysiologically with respect to these different contributions to MS, and I thank you all for the attention.
Thank you, Amit. We'll take questions when we have our panel discussion after the next 3 presentations. So I get to go next. I'm going to talk about the MS diagnosis and the clinical courses. So I have no disclosures that are relevant to this presentation. My full disclosures are in the package from academic CME. So diagnosis of MS has evolved over centuries. The most recent iterations, of course, are McDonald criteria of 2001, 25, 2010, and 2017, each one making it a little easier to diagnose multiple sclerosis. The big change in 2017, to my view, was the ability to substitute CSF parameters for time. So if you had oligoclonal bands, you didn't have to necessarily fulfill the criteria for time. This idea of dissemination in space and time has been slowly eroding in some ways, and especially in 2024. But if you think about what's done in 2024 in Einsteinian physics, it's the space-time continuum. And so space is time, time is space, and you'll see that in what we've done here. So there are important caveats to this, and I'll stress this because it's a major issue with mixed diagnosis, that the criteria that are developed for diagnosing multiple sclerosis, are dependent on typical clinical syndromes. These are the typical clinically isolated syndromes of an optic neuritis, of a distinct cerebral syndrome, cerebellar brainstem syndromes, or a partial myelitis, and now an optic neuritis as well. And they should last for at least 24 hours and such, and fulfill the usual criteria for those. The reason why we want strict definitions for this and characteristic lesion topographies, which I'll explain a little more, is to lessen the risk of misdiagnosis. It's not necessarily biological whether a lesion touches the ventricle or is separated by a little bit, but it is important for diagnostic criteria. And so, as always, we've depended on the MRI, and in the McDonald 2024, we depend on MRI even more. And so we have the very typical topographies of periventricular, juxtacortical here, spinal cord, posterior fossa, cerebellar or brainstem, and now, in 2024, here it is, the optic nerve is the 5th topography. This came up in 2017, and it didn't pass muster to the chagrin of the neuro-ophthalmologists, but by 2024, there's enough data to say, yes, this should be included as a critical topography for the lesions of multiple sclerosis. And then the idea of misdiagnosis has become very important. It happens 10 to 15%, even at MS subspecialty centers. One has to use caution when applying the MR criteria for dissemination in time and dissemination in space, and adhere to these strict definitions, and use only these typical presentations that we've gotten. The main cause of misdiagnosis have been misinterpretation or overinterpretation of the MRI scan. And of course, the consequences are listed there, including people being put on disease-modifying therapies that are unnecessary for them. And also the anxiety and distress that's caused from a misdiagnosis. So there's a long differential diagnosis for multiple sclerosis, more than I can include on one slide. Many things to think about. Certainly B12 deficiency is one of them, as are vascular malformations, a patient with progressive spinal cord disease. But all of these are important. And of course, over the last 2 decades, We've seen the importance of NMO spectrum disease and more recently anti-MOG disease, MOGAD, and so those need to be thought about in terms of differential diagnosis. So the lesions of the characteristic topographies are juxtacortical, and the importance here for diagnosis, not necessarily for biology, is that these touch the ventricle, or even better, are intracortical. So it's a combination of both juxtacortical and intercortical. And what you see here on the left is comparing multiple sclerosis to small vessel disease, and similarly on the right, comparing periventricular lesions. So as you can see here in the ischemic small vessel disease, you can get periventricular lesions with small vessel disease, just as a stochastic phenomena. So one has to look at the whole assembly of lesions over the course of the MRI, the slices of the MRI, to make these distinctions. Now, we've come up with some things that are new. What would be next? Well, diagnostic biomarkers would be of importance. We don't yet have fluid biomarkers that are diagnostic, but I'm going to leave that to Hans Peter to discuss on his presentation. But we do have two MRI measures that I think Gio and I will discuss in greater detail, but I'm going to discuss them anyway for a bit, the central vein sign and the paramagnetic rim lesions, and you heard a little bit about these already from Amit Bar-Or. And so this is the group, if you could see in the picture there, that did the McDonald 2024 criteria when we met in Barcelona in 2023. It was an interesting meeting that had remarkably more consensus than one normally would expect from a group of neurologists, and I think that was due to Professor Montalban's chairing of this session. But in any event, the idea was to advance our ability to diagnose, be able to diagnose earlier, and also to discuss more about the mechanisms. And two of the things that came out of that was this idea of the central vein sign, which is particularly characteristic of multiple sclerosis. Not diagnostic of multiple sclerosis, but very highly suggestive of the disease. And that is, as you can see, I'm going to show you actually some better pictures of that. Here. So let's see if I can pick these out on here. I think I have even a better one. Here it is. Okay, so here shows you the idea of the central vein. And it's part of the pathophysiology of MS that you see lesions expanding out from a vein due to the fact that that's the area where we think it's most likely for cells to egress from the vasculature into the tissue. It's also the area that has the slowest speed of conduction, rheology, so it makes it easier to grab lymphocytes and have them move out of the central nervous system, and that's what you're seeing here, these central veins. This shows you the value of higher field strength when you look at central veins. So here is at 1.5, and this is using the same patient. You could see it here at 3 Tesla. You see it much more prominently at 7 Tesla and such. And so you can see it on any scan that we commonly use, but the more strength you have, the better it is. But more importantly, you have to have a clinical MRI scan that's going to show this to you. And that is a bit of a problem because not all of the makers of MRIs have received regulatory approval to use the sequences, the susceptibility sequences, that are most useful for looking at central vein, including at my institution. So we try to look at it as susceptibility, but there are better imaging sequences than susceptibility, but they're not always available. And then you may say, well, and I'll come back to why they got into the thing. So here's, again, more information on the central vein side. I'm not going to spend any more time on that. But how you rate it was of some interest. And there's a number of different ways that that's been done. One was 40% of the lesions having central vein. The other was Select 3. The one that was chosen in McDonald was the Rule of 6 or Select 6, which is if you could see 6 lesions if there's more than 6 that have the central vein, then that qualifies. If there's less, then you want to see the majority of the lesions having a central vein. And then you heard again about paramagnetic rim lesions, again, highly suggestive of multiple sclerosis. Not yet diagnostic, but highly suggested. And then you heard this new concept of the broader lesions carrying a worse prognosis. All paramagnetic rim lesions, which could be seen as early as in RIS and moving forward, portend a worse clinical course. Not necessarily progressive disease, but a worse clinical course. And as you heard, that this is iron-latent microglia at the outset, and they give you this rim here where these arrows are, the red arrows. That hypodensity is the paramagnetic rim lesion. Again, highly specific for multiple sclerosis. So they're in the new criteria. They're not essential for the diagnosis. Most centers aren't yet getting the sequences that are necessary to see either one of these. But as a group, when we met in Barcelona, we felt that part of our job was to move the field forward to encourage the use of these. And so we all went home and started bugging our radiologists about trying to get these sequences put into our MS criteria. We haven't been successful yet, but we're working on it. But it's similar for others. And so you don't have to have them, just like you don't necessarily have to have an MRI if you're in a resource-poor area, but it's become much more important to consider them. And then the other big change that came out of Barcelona was the use of the kappa-free light chain index, and maybe Xavi can answer it, whether kappa-free light chain as a numeric quantity in and of itself, rather than the index, would also count. This is the equation for doing the index. But it was the idea that these kappa-free light chains are increased in multiple sclerosis. They correlate, I can't give you a percentage, but they correlate with oligoclonal bands, maybe a little more sensitive. And it's nice because it's a metric that's measured rather than someone reading a gel. And so that became a substitute for oligoclonal bands. And so this is the algorithm that came out of the diagnosis. And that someone presents with a typical clinically isolated syndrome, as I had discussed. And you do not find reason to exclude them, which is the part of the no better explanation part of all of our diagnostic criteria, that if everything's still pointing towards MS, you then can see if they have lesions in 2 or more of those critical topographies, or in patients with progressive disease, 12 months of progression and 2 or more spinal cord lesions, then you can diagnose multiple sclerosis if you have 1 or more of the following demonstrated, which would be CSF positive oligoclonal bands or kappa-free light chains, positive central vein sign, dissemination in time. Remember, dissemination in time is either the development of new lesions from one scan to the next, or the presence of enhancing and non-enhancing lesions on a single scan, or a patient who's had more than one attack. And then if the lesions are present in 4 or more of the topographies alone, and this is where time again has been dropped down as a priority, so you don't have to make time if you have 4 or 5 of the topographies involved. Now, on the other side, if you only have 1, a juxtacortical lesion or a periventricular lesion that's typical of MS, or 12 months of progression, then you need to have 1 or more of these below, either CSF and central vein, CSF and pearls, dissemination in time, as I mentioned, and a central vein sign or dissemination in time, and a pearl. And so this may seem it is a little bit complicated, but when you start to get out and use it in practice, it's not that difficult. And then this was another major change, and that was bringing radiologic isolated syndrome into the diagnosis of MS. So in 2017, it was listed as possible MS if you had an MRI that looked like it was MS, but no clinical episodes that were typical of MS. Same thing here. So incidental findings on an MRI, initial workup does not come up with some other diagnostic possibility, then if you have lesions that are present in 2 or more of the topographies, and you either have positive CSF, positive central vein, or evidence for dissemination in time, you now can make a diagnosis of multiple sclerosis. And I think that is the essence of the 2024 criteria. So we've made it easier to diagnose multiple sclerosis. We're hopeful that we won't see an increase in misdiagnosis. In fact, we hope to see a decrease, but we'll see in time. So MRI has become an essential tool in most circumstances to diagnose MS. But if you're in an area, if you're in Antarctica, and you don't have an MRI, you still can diagnose multiple sclerosis clinically by the old-fashioned way of dissemination in time and space. We hope to make diagnosing still easier as we review new ways of looking at the disease. The new diagnostic criteria include new MRI features, central vein and pearls, but they're not essential for diagnosing MS. Okay, clinical spectrum. So there was discussion about this around this morning. The phenotypes that we've used over the decades to look at MS, the relapsing phenotype, relapsing remitting, secondary progressive, primary progressive, and what can we do and how can we do better? So let's look at what we have. There's only 2 ways that individuals worsen with multiple sclerosis. One is relapse-associated worsening, RAW, and I stole this slide from Carmen, and the other, and that's the residual, after someone has an attack. Now, the percentage of individuals who have residual after an acute attack very much depends on how hard you look for residual, but it's at least 50%. And then there's progression independent of relapse activity, PIRA, right? PIRA is not new, it's progressive disease. But it's a nice characterization because it's enabled us to look earlier than we thought progression occurred. And so that concept has been important. But that's it, that's the only ways that individuals can get worse. So we have relapsing forms of disease with, here, without any residual, here more realistically with residual that builds up on time, and we have progressive forms of disease with or without superimposed relapses. And you get superimposed relapses on any form of progressive disease, and we've seen this as a confound of our studies of progressive disease and trying to look at what best describes the treating of progressive pathology versus relapsing pathology. What's been very important, we tried to make important, that's been ignored by regulators, is the idea that we want to look at MS more dynamically. And we tried to do this in 2013 by saying, well, let's look at the individual in time and determine whether they're active over some period of time or not active, whether they have relapsing disease or progressive disease. Active being having had a relapse or a new MRI lesion. But one of the critical elements, and the one that has not been paid attention to, was that had to be framed in time. We said that at least 1 year, and 1 year is a good time period, but there's some studies that have looked at 2 years and said, no, they weren't active at 2 years. It doesn't matter what time frame you choose, but you have to have a time frame. And that was the essence of activity, and you can see in some of the labeling now, for example, active or non-active secondary progressive MS. And what the label doesn't tell you is, well, how did you define activity? Because all secondary progressive MS was active at some point in time. You couldn't have made the distinction into secondary progressive without that, because they all started with relapsing disease. And then for progressive disease, it was the same thing, a dynamic aspect, recognizing that progression in MS is not inexorable. It can plateau, it can stop. And that's very hard to predict. But it's something that one can look back on and say, well, over the past year, has the individual progressed or not? And this morning was the PROMS talk, and this becomes very important for looking at progressive disease. Say, how do you feel over the past year? And very often, the patients will tell you that they're getting worse before you pick it up on their clinical exam. But it's a measure, it's a dynamic measure, whether they were progressing or not progressing. So we talked about these 2 mechanisms of how they build up over time. And what's kind of critical in understanding these is that they're definitional. And PIRA is very much a definition. It sounds very simple. Progression independent of relapse activity. And if you have someone who's never had a relapse, then all of their worsening is PIRA. Once you throw in relapsing disease, it gets a little more complicated. And so this is some work that we had done with the Novartis data set that was sent over to the Oxford Big Data Institute, looking at the relative frequencies. And what we did in this particular study was we used a very stringent definition of PIRA, meaning that we wanted it to be sustained, that it never got better, because otherwise it becomes reversible PIRA, and that biologically kind of is a confound and one that I don't fully understand. But we also utilized a non-stringent definition of a relapse, and that would lessen the ability for you to see actually PIRA, because more would be called relapses. And when you do that, if you look at the bottom screen here, this is from phase 3 clinical trials, you see that over the course of those studies, which is only about 2 years, there was about equal percentages of RAW and PIRA contributing to the disability. Now, others have reported other frequencies, some much higher. It all depends on how you want to define it. And so moving forward, when we talk about PIRA, it's going to be very important for whoever's talking about it to say how they defined the PIRA. For example, some people use a 90-day period after a relapse, which is fine, it's a definition, but Marcus Koch showed that in fact recovery from a relapse can take up to a year, with almost 50% not recovered at 6 months. So this is something we have to think about. Again, it's very definitional. Now, as you get into progressive disease, of course, the PIRA aspect becomes much more prominent, and relapses have very little contribution to those because PIRA is progressive disease. And this is a way of thinking of the clinical course ontology, and some used to think that primary progressive was a separate disease, but the bulk of the evidence suggests it's all part of one concept here. And if you start with radiologic isolated syndrome, it goes on to clinically isolated syndrome, relapsing remitting, which may go on to secondary progressive MS. But a percentage, about 10%, go from radiologic isolated syndrome to primary progressive MS, which really is a way of linking the underlying biologies of those diseases. So we like to think of MS as one MS, which may have MRI onset, attack onset, or progressive onset. And then thinking about how we're going to modify this, because I think there's great need for modification of the clinical courses to A, be more dynamic, and B, be more reflective of the underlying biology. The latter is easier to say than to do, but we're trying to be more biological. And you saw some of this from Alan Thompson this morning. Look at individuals who have the susceptibility and at risk, which may be genes, and environment, the biological onset of disease, which we don't yet know when that occurs, the prodrome and nonspecific symptoms. More needs to come of that to see how that may guide us in picking up individuals maybe before they develop clinical signs of multiple sclerosis. And some of this involves radiologic isolated syndrome, but some of it not. And so this is, again, you saw this morning if you were there, our idea of a more dynamic approach to the MS disease course, that instead of just locking in the characterizations that we've used in the past, look at this more fluidly and, again, more dynamically, that there be phases or states. I really hesitate to ever use the word stage because it has different implications. But that individuals may be in a relapsing phase, and a stable phase, and a progressive phase, and they may have PIRA either reversible or irreversible. And looking at this over time, where they have periods here where they're stable, they're worsening by whatever measure, and think of it in that way. There's much to be done to try and define these periods. But just thinking of a more dynamic approach, relapsing phases, progressive phases, stable phases, repair phase, And then inflammatory phase, whether it be innate or adaptive, we need things like Professor Baror to help us with immunophenotyping, and degenerative phase, and they're not mutually exclusive. And Alan showed this, but we're thinking about the spectrum of MS in terms of all of these different things. And the only difference about it is not being a spectrum is they could be overlapping. And this is our group in New York, and I thank you for your attention. Next, oh, good, you're here. Next, we're going to hear from Ji-Won Oh, talking about MRI, much better than I did. So, Professor Oh is Medical Director of the Barlow Multiple Sclerosis Program. She's the Wall Family Chair in MS Research and a staff neurologist at St. Michael's Hospital in Toronto. Welcome, Ji-Won.
Thank you, Fred, for the kind introduction and for the invitation to be here. I just have to start with a word of warning. You will see some of the same slides in my talk that Fred just used, but I think Fred, as course chair, really liked my slides, so hopefully I'll be able to give you a little bit of an additional spin on some of the imaging slides. Okay, so this is a slide outlining my disclosures. And just a reminder, here's the QR code that you can use to participate. All right, so before diving into some more advanced imaging measures that are used in clinical practice, and this is hot off the press and fresh, I thought it might be useful to take a few moments to think about how we currently use MRI in clinical practice. And I don't think it's an exaggeration to say that MRI really has revolutionized the diagnosis and monitoring of people with MS. MRI allows us to diagnose MS earlier and earlier. It's really an essential tool that we use for disease monitoring and assessing treatment response. And really importantly as well, we do have, decent ways that we can prognosticate how an individual patient will do. There is this nebulous thing called clinical judgment that we often use, but we're still not that great at predicting disease activity and course in an individual patient sitting in front of you. And this is where MRI also plays a major role because it is one of the very few paraclinical tools that we currently have that seem to have a pretty decent predictive value in the clinical setting. So, what are these conventional MRI measures that we currently use? As we all know, we really focus on identifying lesions in the brain and spinal cord using T2-weighted MRIs. Typically, a typical lesion is hyperintense on T2-weighted imaging. And for diagnosis, we basically look for lesions that are a certain size and look a certain way and are in specific regions of the brain and spinal cord to try to come to a diagnosis. And this is the cornerstone of this concept of dissemination in space. If we give gadolinium, and we often do at diagnosis, gadolinium-enhancing lesions also give us additional information in that these are lesions that have usually formed within the last 30 days. And sometimes in radiology reports, there will also be comments on whether there are T1 hypointense lesions. We refer to these as black holes, and this is simply a subset of T2 hyperintense lesions that have more neuroaxonal degeneration, and we do know that if there is a heavy burden of T1 black holes, this tends to portend a worse prognosis. And then occasionally, in some centers, there also can be comment on whether there is apparent brain atrophy that can be visualized, as well as atrophy of the spinal cord. So this is a series of images, older and newer, that show what some of these typical MS lesions look like, and everybody in the audience is really familiar with this, but as you can see, these are mainly flare sequences that very clearly show the typical periventricular lesions that are one of the key topographies for MS diagnosis, juxtacortical lesions, and actually the panel on the right is from the very recent 2024 diagnostic criteria paper showing these typical lesions, including periventricular, juxtacortical, some infratentorial lesions here as well as spinal cord lesions. And as you know, the optic nerve has now been included as the fifth typical topography, and using MRI as well as other imaging tools, including OCT, as well as neurophysiology tools like evoked potentials, one can now demonstrate lesions within the optic nerve as well. This is a series of images, both old and new, also showing typical spinal cord lesions. The spinal cord is a very, one of the common topographies, and as you can see both axial and sagittal sequences demonstrating pretty typical lesions that we see in the spinal cord in MS. These lesions tend to be usually less than 2 spinal cord segments in length, usually occupy a combination of gray and white matter and are quite discrete. And just wanted to highlight, in addition to T2-based sequences, as you can see from this middle panel here, and I know it's hard to see because of the lighting, T1-based sequences, including PSIR, can be quite accurate at detecting lesions within the spinal cord that are related to MS. So, using simply this detection of lesions in characteristic regions of the central nervous system, MRI is really now an essential diagnostic tool in MS. And this is because MRI facilitates demonstrating these clinical hallmarks of MS, which we know as dissemination in space as well as dissemination in time. And this is summarized in the tables on the right here. In addition, because MRI is such an important paraclinical tool that is now really essential for a diagnosis of MS, there are very clear recommendations that have been published as to the bare minimum MRI sequences that should be used that can adequately detect lesions in the brain and spinal cord, and now the optic nerve as well. So for those of you who aren't aware, this is now the companion MRI paper that's a consensus statement from Magnum's CMSC as well as NAMES. That was published together with the 2024 diagnostic criteria, very clearly outlining what the bare minimum sequences should be for an adequate, that are adequate for a diagnosis of MS and for disease monitoring in MS. And then a very important part of this MRI paper is that standardized image interpretation and reporting is also recommended. So Fred touched on this briefly, but I just wanted to again highlight this issue of when MRI is such an important tool that facilitates a diagnosis of MS, and in the 2024 revisions, it facilitates a diagnosis even more. This is when it's so important to adhere to strict definitions of characteristic lesion topographies in order to minimize misdiagnosis. So just to highlight, and I know everybody knows this, but when we say periventricular, it doesn't mean around the ventricle. It, by definition, absolutely has to touch the ventricle. And when we say juxtacortical, it doesn't mean it's just kind of around the cortex. It actually means that the lesion has to touch the cortex. And this is because whenever a set of diagnostic criteria become quite permissive, misdiagnosis is always a concern. And a number of studies have been done showing that even at MS specialty centers, at large academic centers where we are the referral base for demyelinating diseases, 10 to 20% of cases can be misdiagnosed, and obviously there are huge personal, professional, and societal repercussions related to a misdiagnosis of MS, and this is why it is so important when you have a tool that is so sensitive and facilitates a diagnosis in so many cases that we really adhere to these strict definitions. And I think this study really illustrates it. This was actually a survey of over 200 neurologists who frequently diagnose MS in North America. So many Europeans in the room, you're spared from this. I'm going to confess, I actually participated in this survey, so I probably also contributed to this dismal statistic. But when you ask these neurologists, many who are academic MS subspecialists, to correctly identify definitions of these terms, periventricular and juxtacortical, only 14% of them correctly identified the definition. And then what's even scarier is that when you ask them to apply the terms in a series of 10 cases, only 2% of them consistently got this correct. So that's a little bit scary. It's not that scary because you had to get all 10 cases correct, but these were pretty basic MS cases. And so I think this is just an illustration and kind of something that we should all keep in mind as diagnostic criteria become more and more permissive. So I think it's really clear. Currently, we use conventional MRI all the time in MS clinical practice, and it's now essential as a diagnostic tool with the 2024 revisions, except in really rare circumstances where you cannot access MRI. But there are other utilities of conventional MRI in clinical practice, and I already kind of touched on this, but again, prognosis is one of them. Despite the art and science of clinical medicine, prediction or prognosis is something that we're still not great at in MS clinical care. And this is because of this sheer heterogeneity that is present in MS. Often we can't really exactly tell which 25 to 29-year-old in front of you will have extremely highly active disease versus those who may have a more milder disease course. So I think this is one of the greatest utilities of MRI in clinical practice as well. And I think the study done by the Barcelona group a number of years ago very clearly illustrated it. And if you just look at that panel on the top, amongst many different clinical and paraclinical features that we often think are associated with MS prognosis, in the Barcelona CIS cohort, what emerged as the greatest predictive factor of developing a subsequent relapse as well as acquiring disability over time was baseline MRI lesion load. And as you can see, I know it's really small, but in the pink here, there even was a dose effect. So very clearly that initial MRI that you have has quite good prognostic value, and I think outside of diagnosis, another really useful way that we can use MRI in clinical practice. And finally, as all of us know, 20 years ago, this wasn't the case that we monitor people with relapsing MS, around annually, but this is now the standard of care because we know that MRI disease activity happens 10 to 20 times more frequently than we can detect clinical disease activity. And because of this, and because we know that developing new lesions over time is strongly associated with developing disability over time, this is why routine surveillance MRIs are really the standard of care for monitoring for disease progression as well as treatment response in people with MS. And there's many treatment guidelines around the world. I'm displaying one, the modified Rio score, but very clearly we know that in individuals with either clinical activity or even subclinical MRI activity over time, this is not a good thing and this warrants treatment escalation. So moving on to the next part of my talk, I'm now going to talk about, so very clearly we have a great utility of typical conventional clinical MRI in MS clinical practice. But despite the fact that so many people around the world for decades have been doing research looking at different advanced MRI measures, it actually has been very difficult to get one of these advanced MRI measures in clinical practice, and there's a number of reasons for that. But what's really exciting is that in the 2024 diagnostic criteria revisions, for the first time since MRI was ever formally incorporated into the diagnostic criteria, which was in 2001, this is the first time we have gone beyond simply detecting T2 hyperintense lesions. So it's a bit of a landmark moment, particularly for those of us who do imaging research, just because, again, very clearly we use typical clinical MRIs in clinical practice for many different purposes, but finally a more advanced imaging measure. In fact, 2 of them have made it into the diagnostic criteria. So you've seen this slide already and just wanted to start. As you know, there's many revisions that have taken place. And I think we've now all had time to absorb it. But very clearly, this set of revisions was a pretty big step forward for the MS field. And when it comes to imaging, I've just highlighted some of the changes. So the central vein sign and paramagnetic rim lesions, 2 more advanced MRI measures have finally made it into the clinical realm because they are part of the 2024 diagnostic criteria. We already touched on this briefly, but the optic nerve has also been included as a 5th topography, and you can use MRI to detect lesions in the optic nerve. And RIS, which, as you know, is an imaging-based diagnosis where people people, incidentally happen to get an MRI without symptoms typical of MS, and they seem to have lesions that are quite characteristic of MS. And in the 2024 diagnostic criteria, in certain situations, people with RIS can now be diagnosed as MS. So all of these changes overall, I really think a little bit, in a way, can be overwhelming. But I think this is a huge step forward for the field because this 2024 revision really was an attempt to incorporate all of the accumulating scientific evidence into one of the most important sets of clinical criteria, which are the diagnostic criteria. It really facilitates an earlier diagnosis and appropriate management in those who biologically have MS. And this is because in certain situations, even in people who are entirely asymptomatic, but they have certain features that are highly suggestive of MS, you can diagnose MS. And then really importantly, because this set of criteria, similar to the 2017 criteria that really facilitated an earlier diagnosis, there are mechanisms embedded within these criteria to prevent misdiagnosis, and actually the imaging markers, the central vein sign and paramagnetic rim lesions, are two of the key ways that misdiagnosis can be prevented if they are used. So just really quickly, just to highlight, you've heard a lot about the central vein. Obviously, I'm very excited that it's in the new diagnostic criteria, but this is actually not new news in any way for the field. Back in the 1800s, Jean-Martin Charcot, who somehow seems to have described everything in MS as well as many other neurological diseases, already described back then and very nicely illustrated in textbooks that MS lesions form around central veins. And we know that perivenular inflammation and demyelination is a pathological hallmark of MS. But the reason in the last decade there's been so much focus on central veins is because we finally have iron-sensitive MRI sequences that are sensitive enough to detect a central vein if it is present in a white matter lesion. And as you know, there's many different reasons why people can have white matter lesions in the brain. But if you use an iron-sensitive sequence and you can actually visualize it, the likelihood of a diagnosis of MS is very high because the pathological hallmark of MS is perivenular inflammation and demyelination. So just to show you these pretty pictures again, courtesy of Dr. Pascal Satie, who developed one of the preferred iron-sensitive sequences to detect central veins. As you can see, this is a 3 Tesla MRI. And this is a sequence not yet commercially available, but hopefully that'll change soon. So this is a sequence that can be acquired in about 6 minutes. And as you can see many white matter lesions. And when you use this iron-sensitive sequence, you can very nicely see the black line that is a central vein. And obviously, depending on the way you cut the lesion, sometimes the central vein can look like a line, just like you see here, but sometimes it can also just look like a little dot if you cut the vein as it's coming out at you. Whenever there's a new imaging measure that's incorporated into a set of clinical criteria, there always is a little bit of panic in the community about accessibility. And this is really a key piece as to whether some sort of advanced imaging measure actually makes it into the clinical arena. And as you can see, this is the same patient, same lesion scanned at 3 different MRI platforms. So the top row is 7 Tesla, high field. Many sites do not actually even have access to a 7 Tesla MRI, and these are most definitely not available clinically. The middle row is the same patient scanned at 3 Tesla, and then the bottom row is your typical routine clinical scanner. Most scanners around the world are still 1.5 Tesla, and as you can see, although very clearly at 7 Tesla you can visualize the central vein more clearly, you can still see it pretty nicely even at 1.5 Tesla, which is reassuring because by far the most common clinical platform is still 1.5 Tesla. And at 1.5 T, if you give gadolinium, the central vein becomes even more apparent. And so these are certain things to keep in mind as we're thinking about implementing sequences like these clinically. So since the central vein sign has been discovered, and many, many years ago, the North American Imaging Cooperative got together and came up with a set of criteria as to how one might identify central veins. Since that time, because it's so clearly a useful diagnostic biomarker, there have been so many studies done around the world that it's been enough material for 3 separate systematic reviews and meta-analyses. And as you can see, what these systematic reviews have shown us is that the sensitivity of the central vein sign is around 95 to 97%, so it facilitates a diagnosis of MS quite a bit. And the specificity is 92 to 98%. So it's a measure that is highly specific for the diagnosis of MS, which also prevents misdiagnosis. So when it comes to diagnostic measures, it actually doesn't get much better than this, because often when there is some sort of measure that facilitates a diagnosis, the issue will be that it actually increases the rate of misdiagnosis, so isn't that specific, and vice versa. But when it comes to the central vein sign, having a very high sensitivity and specificity are kind of the best diagnostic properties you can have for some sort of measure. So as the central vein sign was being developed, a number of methods were evaluated to see how you would use this in clinical practice. And it seems very clear that the most robust method is something called the 40% threshold, where you have to look at every single white matter lesion. And if 40% or more of them are central vein sign positive, then the likelihood of a diagnosis of MS is very high. But if somebody has 6 lesions or 10 lesions, it's not that big of a deal. But as you can imagine, when someone has anywhere, 30 to 100 lesions, radiologists really do not like doing this. And in many of the studies that we did, I really had to beg some of my excellent neuroradiology colleagues to be the rater on these studies, because it can be quite cumbersome. And so this is why simplified methods were evaluated, which include SELECT3, SELECT3 star, and the rule of 6 or SELECT 6. I just bolded SELECT 6 because this is what's made it into the diagnostic criteria. And what this refers to is when you have a whole bunch of white matter lesions, if you identify 6 with a visible central vein, then SELECT 6 is positive. But when you have 10 or less lesions, so not so many lesions, as long as you show that more than 50% of them are central vein sign positive, then you have SELECT 6 that is positive. Initially in the development of SELECT 6, it was stated that if you have 6 or fewer lesions, you have to show more than 50%. But in further discussions with the Diagnostic Criteria Committee, we thought a better number would be to use 10, because when people still have less than 10 lesions, sometimes because of different exclusion criteria, it's actually hard to identify that at least 6 of them have central veins. Moving on, this has already been discussed by both Amit and Fred, but really quickly, there's a lot of excitement in the imaging field with respect to detecting paramagnetic rim lesions, and it wasn't actually related to diagnosis. It's because we know that PRLs, again, when you use these same iron-sensitive sequences that are used to detect the central vein, we know that PRLs represent at least a subset of chronic active lesions, which we want to be able to image, because we know chronic active lesions are one of the drivers of progressive disease biology. So there's been a lot of investigation into looking at PRLs, but as an added little bonus, what emerged from many of these trials was that PRLs actually are highly specific for MS as well. And so despite the fact that it's not really the reason why there's so much excitement in the field about pearls, because they're so specific for MS and they're seen across the spectrum of MS, they're not as sensitive for MS as the central vein sign, but the specificity makes it, again, a pretty useful diagnostic biomarker, and this is why it's also made it into the MS diagnostic criteria. So in this discussion, again, I'm going to touch on some of the practical implications of this in just a second, but just wanted to emphasize, because as we were talking about all the new revisions of the MS diagnostic criteria, I found often with community colleagues there is this panic about, but what if you can't access these iron-sensitive sequences? What if your radiologists don't know how to read these sequences? The bottom line is these are helpful, but not essential. So you don't absolutely have to use veins and pearls to facilitate a diagnosis. There's many ways you can still come to a diagnosis of MS. However, they're really useful, again, because these are highly specific imaging measures that help prevent misdiagnosis. So when you use them, Not only do they facilitate a diagnosis, but they can also prevent misdiagnosis. The central vein sign, because there was much more evidence when the diagnostic criteria committee came together, it's been incorporated into all parts of the diagnostic algorithms, including with RIS. Pearls, however, were included only in a small part of the diagnostic algorithm, simply because there's not as much evidence as there was with the central vein sign with respect to their utility in MS diagnosis. I just also wanted to highlight in the companion MRI paper that was published together with the recent 2024 diagnostic criteria revisions, there's a very clear table that suggests sequences for CVS and PRL detection and has all of these statements about what you can do to optimize even commercial sequences that are currently available on many different MRI platforms. Many sites already use susceptibility weighted imaging, or the SWE sequences, and so there are suggestions within this table of what can be done to optimize these various iron sensitive sequences to detect CVS as well as pearls. So just wanted to highlight here, this is the diagnostic algorithm for relapsing or progressive onset from the recent diagnostic criteria paper. And the arrows just show that the CVS has made it into every part. And then as you can see, pearls have made it into one part of the diagnostic algorithm. And then this is for RIS and atypical syndromes. As you can see, the CVS made it into this diagnostic algorithm, but pearls did not. And again, this is only because there was not as much of the full 3 systematic reviews and meta-analyses that the CVS had. And pearls were just at an earlier stage of development, so not as much evidence to support including pearls in every part of the diagnostic algorithm, but maybe that will change in the coming years. In the last couple minutes, just wanted to talk very briefly we talked earlier about how we use baseline MRI lesion load right now as one of the most reliable prognostic measures in clinical practice. And part of the excitement with pearls as well is that, the hope was that these may be useful as a way to measure progression in MS, but it turns out they don't change so quickly, and so we may not be able to use it for that purpose. But what is emerging from many trials is that there is pearls may be useful as a prognostic marker in MS, because a number of studies have shown that pearls have a very clear relationship with global and cognitive disability in MS. So pearl lesion burden, and a cutoff of 4 pearls has often been used. And very clearly, when you have a lot of pearls, you have a lot of both physical and cognitive disability. And even in RIS, we showed a number of years ago that pearls are present in nearly 60% of people with RIS, and in people who have detailed cognitive testing done, pearls are the imaging measure that seem to correlate most with this very subtle cognitive impairment that is present in about 30% of people with RIS. So very clearly, pearls are relevant to disability across the spectrum of MS, and so it is possible that with additional evidence, pearls may be useful as a prognostic measure moving forward. And I think this abstract that was presented earlier this year at ACTRIMS illustrates this point as well. As you know, the Gemini 1 and 2 and Hercules clinical trials evaluated tolebrutinib versus teriflunomide in relapsing MS, and tolebrutinib versus placebo in people with non-relapsing SPMS. But a very interesting subgroup analysis was done recently that looked at baseline pearl lesion load and its relationship to disability progression. So I know these slides are really busy, but just with the top slide, this is actually Gemini 1 and 2. And as you can see, if you look at the gray bars, which are people who were treated with teriflunomide, in people with no pearls, the risk of disability progression over 2 to 3 years was 9%, but in people with any pearls, the risk of disability progression in people treated with teriflunomide goes up quite a bit. And so this is really interesting because a baseline pearl lesion load very clearly is able to predict risk of disability progression prospectively in a clinical trial in people who are treated with teriflunomide or placebo. And similarly in Hercules, you can see this as well. In people who had no pearls, risk of CDP was 21%, that's the gray bar down here. But in people who had 4 or more pearls, the risk of CDP was nearly 40%, so a doubling of the risk of disability progression. So this is really interesting. And then the other interesting thing is the purple bars represent people who were treated with tolebrutinib. And so very clearly, tolebrutinib did have an effect on disability progression, and the treatment effect therefore seems to be relevant to baseline pearl lesion burden. So this is all really interesting because it supports potentially the prognostic utility of pearls, and this may be, obviously with increasing evidence, a way that we might be able to use more advanced imaging measures in clinical practice moving forward. So, last slide. Obviously, anytime a new MRI measure becomes part of clinical diagnostic criteria or even disease monitoring criteria, there's a lot of practical challenges. As you've already heard, the most sensitive sequence for central veins and pearls, the T2-star EPI sequence, is still not available commercially, but hopefully, especially with these recent publications and these clear MRI guidelines, this will change. Again, it's very clear that higher field magnets are better at detecting some of these advanced imaging measures, but still at 1.5 Tesla, you can detect the CVS and pearls when appropriate sequences are used. And then there is this ongoing struggle at many centers about arguing with the radiologists about adding on 5 to 6 minutes of scan time. And then there will need to be appropriate education and training of both neurologists and radiologists. And so this is not to say that these imaging measures, that again, the first time advanced imaging measures have been incorporated into a set of diagnostic criteria will be immediately available. But because of the real practical utility of these measures in that they facilitate an MS diagnosis, but if you use them, you can also prevent misdiagnosis because they're so specific. Hopefully, there will be a recognition in the field over time of how useful they are, and they will be able to be widely implemented. Finally, just wanted to touch briefly on other advanced imaging measures because I was asked to talk about advanced imaging measures in clinical practice. It really is just the CVS and pearls. And you might ask, why is that? Because there's so many labs around the world looking at many different advanced imaging measures, and it's because an advanced MRI measure actually needs to meet a really high bar to become useful clinically. So not only do you have to demonstrate its utility as either a diagnostic or prognostic or disease monitoring tool, but these practical aspects are really what kill many advanced MRI techniques when they're trying to translate into clinical use. So if something requires this really complicated long sequence, and if something requires really complicated post-acquisition processing, and there's no clinically actionable threshold, then it will never make it into the clinical arena. And this is why so many of these advanced imaging measures that we all work on in many of our labs will never really see the clinical light of day, but this is not to say that they're not useful scientifically. Cortical lesions, just wanted to note, are a part of the MS diagnostic criteria, but they were grouped together with juxtacortical, and this was back in the 2017 revisions. And these can be helpful for MS diagnosis, but these require specialized sequences and really high field platforms. And so this is why, unless you're at a special center that focuses on cortical lesions, they're really rarely used for diagnosis. And then we're all really familiar with whole brain atrophy, which has been used in clinical trials for decades. And recent results of clinical trials have actually brought up this question mark about how useful they are as an imaging biomarker of progression. But because in order to get a measure of whole brain atrophy, it requires post-acquisition processing, it's really not useful in clinical practice for diagnosis, and there's unclear utility for monitoring disease progression, particularly with the results of recent clinical trials, including Hercules and OHAND, as you're familiar with. Okay, so I hope I've been able to show you how we use MRI as an essential tool currently in MS clinical practice, so these conventional measures that we use. And for the first time, the 2024 McDonald criteria finally include 2 new advanced imaging measures, central veins and pearls. They're highly specific and can help prevent misdiagnosis, and they also facilitate a diagnosis of MS in many cases. Emerging data suggests that pearls may eventually become useful as a prognostic tool. If we're using them for diagnosis, then we know how to acquire them, so this is why there is potential for this. And currently, other advanced measures are not yet ready for use in clinical practice, but there is hope. It's a high bar, but amongst different imaging measures, if they do meet that practical utility, it is very possible in the future that we will have more advanced imaging measures. So thank you very much for your attention, and I look forward to discussing more with you.
Okay, next up is fluid biomarkers from Hans-Peter Hartung, who is professor of neurology in the Heinrich Heine University in Dusseldorf and also co-chair of ECF. Peter.
Thank you very much, Fred. Good afternoon. I would like, or I was tasked to discuss fluid biomarkers in MS. I will start with some basic background outlining the multiple roles that fluid phase biomarkers may subserve. Then mention just the various body fluids that are accessible and available for interrogation. And then really spend most of the time talking about the 2 most widely used fluid biomarkers, serum neurofilament light chain and glial fibrillary acidic protein, GFAP in short. I will come back to what Professor Lublin mentioned in the context of the latest revision of the McDonald criteria, the use of kappa-free light chain, perhaps substituting, replacing, or being used alternatively to OCB, and then briefly touch on the role of chitinase 3-like protein 1, and basically, well, looking into the future, briefly touch on proteomic technology and first results to identify fluid phase biomarkers. So obviously there are a number of roles for fluid phase biomarkers. They may aid in the diagnosis and differential diagnosis within the spectrum of inflammatory demyelinating CNS diseases, aid in immunophenotyping clinical variants, detect disease activity, and I think this is particularly relevant in the context of our discussion of PIRA, predict and monitor disease progression, and hence may allow to stratify, individualize, and monitor disease-modifying treatments. Surely the most used and most easily performed accessed fluid is blood, but we also know that you can detect biomarkers in the urine or in tear fluid. I don't want to speak about stools. It's a slightly unpleasant kind of substrate, but there's also some interesting, maybe not so fluid biomarkers that can be detected there. So let's talk about neurofilament light chain. You've heard and seen many, many papers coming out on the topic. Type 4 intermediate neurofilaments with the various subunits, and they are light chains and heavy chains, and they are released into the interstitial fluid by axonal injury and neurodegeneration. And the breakthrough for their assessment, not just in the CSF, but in the blood, was the introduction of the single molecule array immunoassay some 15 years ago, allowing to detect with high sensitivity various molecules. I mentioned that there has been an explosion of publications on neurofilament light chain in multiple sclerosis, and I listed just a PubMed graph, or showed this, and some older and more recent reviews that I think are useful to resort to. And in this paper review by Thibault and colleagues, some of the characteristics of a useful biomarker as they relate to SNFL in multiple sclerosis are depicted. Obviously, you can pick up inflammatory disease activity. You can capture, to some extent, disease progression, assess treatment response, and may also use this to predict and estimate the prognosis. The caveat is that, and I already alluded to it, that NFL levels are certainly not disease-specific. There are multiple, both physiological and pathological factors that impact, very importantly, and one has to consider that age and BMI, but there are illustrated a number of conditions from trauma to neurodegenerative disorders, Parkinson's, Alzheimer's, motor neuron disease in the periphery, Guillain-Barré syndrome, CIDP, you name it, elevated NFL levels have been described. So one needs to be cognizant of this, and it's also useful to look at the two papers that I referred to or referenced that underscore this and also take account of the age-dependent facts. So using a Z-score allows to correct this and not use falsely elevated or physiologically elevated levels as evidence for a pathogenic effect. Now, some 10 years ago, it was this paper from the Swiss group that reported first serum neurofilament lights as a biomarker of neuronal damage in multiple sclerosis. In the upper panel on the right, you see the various levels of SNFL in healthy controls, CRS, early RMS patients, and in those with progressive disease. And you see that the median goes up. There was also a correlation with EDSS in all these subtypes of multiple sclerosis, and as I mentioned earlier, this increase as one ages. This is a paper from Xavier Montalban's group looking at the diagnostic contribution of blood biomarkers in general, but in particular here with regard to SNFL. Close to 200 patients were studied within the large Inception cohort of Barcelona. They were split into 14% of patients without evidence of dissemination in space or time, 34% with evidence of dissemination in space but not time. About half of them had both dissemination in space and time, and it was looked at a potential contribution of SNFL Z-scores. And the result was, as you see in the graph, that in this smaller group without evidence for dissemination and time, it was high SNFL Z-scores that best predicted the development of MS as defined in the 2017 criteria. this study was conducted before the latest rendition of the diagnostic criteria. Now, one note of caution as regards, the SNFL being a very sensitive, robust indicator of disease activity was looked at or emerged from the RESTORE trial, where patients were continued on natalizumab or discontinued, and the levels of SNFL correlated with MR evidence of acute disease activity. And although SNFL correlated with the presence of GAD lesions, most participants with GAD lesions did not have elevations in the levels. So there is some reason to carefully look and interpret findings. Now, another important area of study is what happens to SNFL in response to DMTs. Would it be able to serve as a treatment response marker? And Novartis looked at their 3 trials in SPMS and relapsing multiple sclerosis, and found that patients with SPMS, the EXPAND group, have higher serum NfL levels than patients with relapsing MS at the same age. And in SPMS, high serum NfL is associated with low SDMT scores and greater brain volume loss at 2 years. And looking again at correlations with measures of disease activity and burden, there was this clear aggregate evidence that NFL correlates with MR lesions, relapses, brain atrophy, disability progression. Similarly, looking at anti-CD20 monoclonal antibody therapies, here an analysis of SNFL levels prior to and following exposure to ocrelizumab on the left-hand side in the 2 twin trials in relapsing multiple sclerosis, on the right-hand side in the PPMS oratorio trial. And clearly, again, there was a response, particularly on the left-hand side in the relapsing population, comparing with the active drug interferon beta-1a, but also in oratorio of SNFL levels following institution of ocrelizumab therapy. And just to summarize data that were then also presented from other DMTs, so it's a very uniform finding that alemtuzumab, cladribine, mitoxantrone, natalizumab, S1PR modulators, ocrelizumab, and ofatumumab displayed the same effect on SNFL levels. If we talk about progressive multiple sclerosis, this is a now somewhat dated review looking at the published data in this population, and as an executive summary, it emerged and has been confirmed over subsequent years that SNFL at a group level is a biomarker for active neuroinflammation, future brain atrophy, disability, and treatment response also in progressive multiple sclerosis. I found this also interesting, a study from the Brigham group looking at both SNFL and SGFAP, which I will talk about in a minute, in relation to cognitive impairment in active progressive multiple sclerosis. And as shown, depicted on the right-hand side, in this group of 94 patients, where single digital modality test as a reflection of cognitive functionality was assessed over some 3 years, and these two biomarkers quantitated by the Simoa assay, they found that SNFL but not SGFAP associated with concurrent or future SDMT. So much for SNFL, and now we'll turn to the second now most popular, if you like, fluid phase biomarker, gliofibrillary acidic protein, or GFAP in short, a type 3 intermediate filament of 50 kilodalton molecular size, and just important to sort of recall the multiple fundamental roles of astrocytes in both normal and diseased brain astrocytes. I mean, the astrocytes are crucial elements of the blood-brain barrier and their functional integrity, synaptic function, and play an important role, of course, in astroglial metabolism. GFAP is elevated with astrocyte activation and astroglial proliferation and scarring. So there were two reports that started a more detailed look at SGFAP in multiple sclerosis, and they showed an elevation of SGFAP in relapsing MS compared to healthy controls and non-inflammatory neurologic disease, a correlation with disability, MR lesion load, SNFL and brain atrophy, although I must say some of the subsequently produced evidence was not absolutely congruent, and SGFAP levels were inversely correlated with white matter, gray matter, or cortical gray matter volumes. In progressive multiple sclerosis, about half of the patients in this particular study showed elevated SGFAP levels associated with accelerated gray matter atrophy, but not white matter loss. The combined elevation of SGFAP and SNFL Z-scores conveyed a 4- to 5-fold increased risk for confirmed disability worsening when compared with a stable control. And you also see on the right-hand side from this study from Basel that SGFAP was also or differentiated between PIRA to some extent and non-PIRA progression. I wrongly used the term transition, let's say conversion, and SGFAP, as very recently reported, predicts the conversion of relapsing to SPMS. I mean, if we stick to these categories, you see on in green the absent conversion, and in red or violet the percentage of patients or the levels in SPMS. Clearly, SGFAP predicted the conversion to SPMS. Now, this is another study from the Weiner group and in collaboration with others studying 2 CIS trials and examining levels of SGFAP, and as shown on the right-hand side, determined what risk was conveyed by SGFAP levels and SNF levels to develop 6-month confirmed disability progression. And the short summary is that higher levels of SGFAP did correlate with subsequent progression, and the authors suggested that determination of SGFAP and SNFL may be used to stratify patients with progressive MS for research studies, clinical trials, and may inform clinical care. Coming back to what Professor Lublin mentioned already, the role of kappa-free light chains in the CSF in the diagnosis of multiple sclerosis. He mentioned that with the 2017 rendition of the criteria, the presence of OCB was taken as evidence for dissemination in time, and it was possible then to eventually, what the European colleagues always longed for, to include OCBs in the diagnostic criteria. In the more recent version, the kappa-free light chains were again alternatively to oligoclonal bands taken as evidence for dissemination in time. This is just to remind you of the difference. OCBs, a qualitative measure, nominal, labor-intensive, rater-dependent, do have high diagnostic sensitivity, no doubt. And the determination of kappa-free light chains, which are produced in excess in multiple sclerosis or with any B-cell stimulation, is metric. It can be easily done quickly, rater independent, and is methodologically done with nephelometry or turbidimetry. And there are a couple of studies that looked side by side at the sensitivity and specificity of OCB versus kappa-free light chains in different MS populations, as pointed out up there. And on the left-hand side, you see kappa-free light chains are elevated in multiple sclerosis. On the table on the right, you see the various variables that were compared, and the summary is, in this particular study, KFLC performed slightly better than OB, but basically, as shown in another review published by Hagen and colleagues, that basically the diagnostic accuracy of KFLC and oligoclonal bands is similar. And this then led to the inclusion of KFLCs as a reflection of dissemination in time, substituting or replacing oligoclonal bands of the 2017 criteria. Again, similarly to the findings reported by the Barcelona group, and I think Professor O already showed one slide, the colleagues compared the prognostic value and utility of kappa-free light chain index in the CSF and oligoclonal bands for the evolution of, in that instance, 27 McDonald evidence on MRI of dissemination in space and time, and they found that the risk for second attack was clearly predicted by KFLC levels, and they looked also quantitatively to grade this risk. So clearly identifying kappa-free light chain in the CSF as a biomarker heralding the further development of multiple sclerosis. And this is a French study looking at the kappa-free light chain index in terms of predicting the disease course in both radiologically isolated and clinically isolated syndromes. And these authors found higher KFS-CL indices associated with the faster appearance of T2 lesions and transition to CIS in patients with RIS. We look at the longer-term evolution of multiple sclerosis. This German-Austrian study looked at kappa-free light chain index in relation to the development of long-term disease activity and disability accrual, and again found that the presence and the level did sort of predict the accrual of disability in multiple sclerosis. And this is, again, a very recently published paper looking at KFLC in primary progressive MS, just looking at this in comparison with OCB and once again demonstrating similar positivity compared to OCBs and frequency in also primary progressive multiple sclerosis. So much for GFAP, and I will turn to chitinase 3-like protein 1, a 40 kilodalton secreted glycoprotein with multiple cellular sources, which in general has been shown to be involved in inflammation, tissue remodeling, cell growth, proliferation, and angiogenesis. And I think there's been now a history of studies started by Comabella and colleagues in Barcelona looking at chitinase 3-like protein levels, initially in CSF. It's also now possible to detect it in peripheral blood. Was found to be increased in MS versus CIS versus healthy controls, higher in converting than non-converting CIS, higher in PPMS than relapsing MS and SPMS, and associated with long-term disability in progressive multiple sclerosis. This is a review and meta-analysis of the studies devoted to looking at chitinase levels, and the forest plot sort of clearly shows that the vast majority of studies do confirm that levels of chitinase are elevated in progressive versus relapsing multiple sclerosis. Finally, I will conclude by briefly showing you a couple of studies that are very interesting, looking at some signatures, sort of moving from single molecule determination to the identification of signatures predictive for multiple sclerosis. And this is one paper, don't want to go into the details, published in Nature Medicine last year, that was able to define specific signatures present in detectable in multiple sclerosis in two cohorts, I think one from UCSF and the other from the Department of Defense, or now you call it Department of War Serum Repository. And another paper from Boston and San Francisco, looking combined at 3 MS cohorts, 630 samples, and looking at 1,400 serum proteins, could identify a set of 20 proteins that were associated with clinical and MR activity. And in this, as also in the previous study, neurofilament light gave a very high signal, confirming the other more traditional studies conducted on SNFL. So, in conclusion then, biomarkers may be informative of the MS pathogenesis. This has been initially alluded to, I think, by Professor Bar-Or and Lublin. I've shown those three that are most commonly used. There are others that I didn't have time to go into. They may help to elucidate novel targets for treatment strategies and also inform clinical management of patients. And how could this be applied in the management of MS as it evolves? This is from a nice review published in Lancet Regional Health Europe. So at the risk phase of MS, the determination of NFL may help to identify patients carrying a higher risk to develop multiple sclerosis. There may be a role of the biomarkers, fluid phase biomarkers, at the time of diagnosis, and as the disease goes on in terms of reassessing diagnosis, detecting or characterizing biological subtypes, determining treatment response. So this is entering clinical management, but for most, I think the cautionary note that these results are mainly derived from large cohorts, and how they apply to an individual patient really needs to be determined. And concluding now, of the fluid biomarkers, SNFL and SGFAP have been best studied. I reviewed the evidence for their increased levels detectable in various forms of multiple sclerosis at various stages, reflective of inflammatory disease activity, neuroaxonal damage, disease progression, disability progression, brain spinal cord atrophy, their potential use as a response marker to DMTs. I talked about GFAP and chitinase. The assessment may be particularly relevant, as I mentioned initially, in increasing the comprehensiveness and granularity of neurological assessment, determining PIRA. On longitudinal monitoring, raised levels may alert to new disease activity, and the more recent developments center around the identification of molecular structures extracted from proteomic and metabolomic studies. And as was mentioned a couple of times, the new diagnostic marker of kappa-free light chain has been included in the 2024 McDonald diagnostic criteria. And with this, I'd like to thank you very much for your attention.
Thank you very much, and I'm on. So now we have some questions and such, and while people are working their way to the microphones, I have several very good ones here. And starting with you, Peter. So when can we expect fluid biomarkers, specifically NFL, to aid us in monitoring MS and its treatments on an individual level?
Looking into the, what's the English word?
Crystal ball?
Yeah, crystal ball. Personally, I say probably within the next couple of years. Right now, it's not yet prime time, I think. We do it in the context of, sort of research studies setting, but we just try to gather more and more evidence and to get more confident in the utility in an individual patient.
Other thoughts on that?
Well, I think the question makes the important point that what may perform really well at the group level will not necessarily translate in the individual, and that's, I think, the rationale for the question. And like Hans-Peter, although we know how to measure some of these things, we're certainly not yet using them broadly, but we take advantage of certain contexts. NFL elevation, for instance, in the context of asking about a pseudo-relapse versus a relapse. If you're thinking of making a treatment change because of what you think may be a relapse, if NFL is entirely flat, and even in the face of Bob Fox's data, which I think is important, it's helpful. And then if there's an elevation as you monitor, it may force you or drive you to get an MRI to substantiate an actionable type of observation.
Yeah, and there's some data, though, there's a delay before the NFL shows up.
Yep.
So there's a risk in that. So, Gilles?
I have a question for Amit. Do we have some scientific evidence on the relationship between the acute focal lesion and the chronic lesion, in the term that the acute lesion might influence the evolution of the chronic lesion as a bad lesion, smoldering, evolving lesion, or paramagnetic rim lesion? I think it's a very important question, as if acting on acute lesion, we indirectly impact the chronic lesion. It is a very good news for those who receive the actual therapeutic strategy, limiting or reducing or stopping accumulation of new focal lesion, meaning that you might have an impact on the chronic lesion, on the risk that they evolve to bad lesion, responsible of the disability progression.
Thank you. So maybe two perspectives on that. One, of course, if we could prevent the lesions from starting entirely, you wouldn't have ones developing into chronic active lesions. But your question, I think, is a very important one. Are there features that may influence whether a lesion does or does not develop into a pearl? And at the moment, one of the sole predictors is the volume of gadolinium is associated with the risk of that lesion turning into a pearl. And that may reflect something about the intensity. We're very interested in the potential profile, and there are several studies now trying to characterize how a person's peripheral immune response profile may relate to whether a new lesion does or does not turn into a chronic active lesion, because that's one of the interfaces between the peripheral immune response and relapse biology and CNS compartmentalized inflammation and progressive biology. There's also the prospect that there's a relationship between chronic active lesions and the white matter as these perivascular lesions, and the presence of the other aspect of pathology, the subpial cortical and the deep gray. And there are studies that are trying to understand what the relationship is and whether the mechanism is the same. So I think getting a handle on your question may be helpful not just for the chronic active lesions, but for progressive biology more broadly.
And just a second question for Fred. You don't discuss, Fred, in the new phenotyping, or what we should the introduction of progressive, independent, and relapse on MRI activity as an important classification, at least for the clinician at the time of therapeutic strategy discussion.
So maybe because in the past we've said that relapse and MRI activity are the same thing. And so if someone's in an active phase, they're active whether it's relapse, a clinical relapse, or MRI activity.
Yes, but PIRA, you have two possibilities in PIRA patient. You have the possibility to have PIRA without MRI activity and PIRA with MRI activity. And that might be important to distinguish these two conditions at the time you discuss to change the treatment in those who worsen their disability.
Are you familiar with the Heisenberg uncertainty principle? Are you familiar with the Heisenberg uncertainty principle?
I don't know.
So Heisenberg said you can't know the location or the speed of an atom at the same time because one alters the other. Not important. To answer your question, is differentiating PIRA when people are actively having relapses is nearly impossible under our current circumstances. And until we can find better markers of what's truly progression, it's going to be hard to know. Right, because someone has a relapse, you don't know whether they're having PIRA or not.
But we have no clear data demonstrating that in patients having progression without any disease activity on clinical on MRI ground, you have any medication that change the risk of disability progression up to now?
Well, Yeah, maybe you do, right? Tolebrutinib had that data, and maybe we'll see something from the primary progressive study by the end of year, because those were relatively non-relapsing populations. Not perfectly non-relapsing, but enough to be able to get the answer.
But we do the job in patients treated with anti-CD20, and we didn't demonstrate a better income in those who have no disease activity, no clear impact of anti-CD20 compared with those who still have disease activity with MRI.
It helps you interpret those results, doesn't it?
Yes, but okay, we will have discussion about that.
Okay. Okay, so I have a couple more questions here. Just to continue, Amit, it says, a little hard for me to read this, but how do you differentiate, what's the difference between the presence of autoreactive cells and antibodies in the periphery versus the central nervous system? And then the question of whether they're dependent on disease activity and stage.
So I'm not entirely sure what the question is getting at. Very difficult for us to measure CNS autoreactive cells in the very few cells that we get from the CNS, whether CSF or brain. So much more work has been done on the periphery. And the thought of the CNS being targeted is thought to be based on some aspect of cells that can traffic and recognize something from the periphery to the CNS. So I'm not sure I understand the question well enough, and I don't know if someone wants to clarify it.
I don't know if it came from the room or it came from the streaming. Probably came from streaming, but I think the idea is, especially for the antibodies, has there been work to look, like Hans-Peter showed that antibody study that was done in serum, can you see similar results, or do we know if there's similar results in the CSF?
Well, I think that when you have an immune response that has been seeing a CNS target abnormally, you would not be surprised to see that reflected in the peripheral repertoire, both of the T cells and of the antibodies. And so all these nice serologic studies that look at different target antibodies have identified abnormal profiles in MS, but they largely differ across individuals, and they're not that useful yet diagnostically. It may be that interventions that limit autoreactivity in a way that's relevant for the disease could be reflected in those measures, and then they become perhaps useful in terms of monitoring treatment response, for example.
Okay, two for you, Jiwon. One is, this is interesting, it's a good question. Which providers should identify and document the pearls and central veins?
I mean, ideally, it's based on the MRI, so the radiologist should. However, I think it's also neurologists that need to be trained. I mean, similar to what we even do now. As neurologists, I think, despite the fact that we have radiologists reading our scans, we will take a look directly. So I think it's a joint effort, but because it is a radiological finding, it does seem that, at least in the medical record, the onus would be on the radiologist to dictate this.
If it gets into the medical record.
Yes.
Right, because we all read our scans anyways. That's why I think it's an interesting question to bring that up. Probably initially it's going to be us.
Yeah. I mean, the whole education dissemination piece will be really important, and this is why it likely won't be immediately available, but over time, particularly when there is a clearly demonstrated utility.
Okay, I'm going to save your second question because someone's at the mic.
Oh, yes, thank you. It's a question about biomarker. What is your take about IgM oligoclonal band? Is it useful? Do you believe in it, or is it too difficult to test?
Could you say it again?
IgM oligoclonal band.
Yeah, there's this data, particularly from the Madrid group, assigning a prognostic role for IgM OCBs. I don't know of any studies other than from this group who produce the evidence.
There is like lots of studies in Italy, in Spain, in France, about in USA.
Thank you very much for.
Yes, it's showing that after 5 years, it's a good predictor of disability, EDSS.
Yeah. Right.
The presence or numbers?
I'm sorry.
Fred, and both. I can perhaps comment as well. So I think you're right that there's a body of data out there that indicates that if you can measure IgM oligoclonal bands, their presence and number is associated with the degree of disability progression, also the degree of acute relapse biology. Whether the association with progression of disability is all relapse-associated progression of disability raw, or also non-relapsing progressive disease, I don't think we quite know. And one of the challenges has been, as you know, that IgM oligoclonal bands are not that easy. IgM oligoclonal bands are even harder. So Louisa spent a few months with us in Montreal on the pediatric cohort, where we also see the same interesting association, presence and number with disease activity. But it's more of an art, and that is one of the things I think limits using it as broadly as one might want to.
Wouldn't M almost by definition suggest something acute?
So in general, you'd think of the IgMs as being more associated with bursts of initial generation of antibody-secreting cells, with then differentiation into IgG. And that's one of the reasons why it has been thought that maybe they'd be more responsive and more useful because they're more dynamic than IgGs that stay for a considerably long period of time.
Thank you.
Xavier.
Well, yes, following that question, I think is the lipophilic IgM oligoclonal bands, not just IgM, lipophilic IgM. And as you said, it's very difficult to reproduce in most of the labs, and we were able to demonstrate any impact on the prognosis in our CIS cohort with the technique done at the Madrid lab. So I think it's still a little bit controversial, the useful of that. No, my point is that to you on, mainly, I think we have discussed about that, but the PRL thing, the PRL indicating response to tolebrutinib but not to teriflunomide, I think, as far as I know, is the first baseline treatment response biomarker in the MRI or in the biological field, etc., at baseline. I would like to know your opinion. And then another question or comment is that we are now fighting with a new, whatever phenotype, clinical descriptors classification. And apparently, if we have PRL, so we can say that this is there is chronic compartmentalized inflammatory activity, therefore, probably progressive disease. If there are cells, the same thing. What do you think about that? This is in a group level, or is also for individuals? Can be those used in our classification?
So go ahead, Fred.
So for classification, maybe. What they indicate is you're taking something that is focal and trying to make it progressive, which is why one of the things I stressed was it was a marker of worsening disease, because I'm still not sure how to combine the two. I think that relapse activity clearly portends potential for progressive disease. But this is like single lesions in the brainstem or single lesions in the spinal cord. And this focal activity, which is what our Pearl does, also portends it, but I'm not sure where that fits into worsening, progression, et cetera, et cetera. And I think this is something we're going to have to bring up when we think about the classification.
Just to speak to Xavier's point about the treatment response biomarker, yes, I think it's unique in that sense. I don't think I've seen any other baseline biomarker that directly predicts treatment response, and it's entirely related to the fact that Pearl lesion burden at baseline was predictive of disability progression in the control arm, so whether people were on placebo or teriflunomide. And it's a pretty striking difference. I didn't highlight that difference, but there's over a twofold treatment effect in people who have any baseline Pearls in those who are treated with tolebrutinib. Just in terms of the second question about whether having any evidence of a baseline Pearl suggests that there is progressive disease biology, I think every measure that we have has limitations, but at least based on a baseline scan, I think this is what this indicates. And I think we're understanding that there's both relapsing and progressive disease biologies across the spectrum of MS. And in a early relapsing MS patient that does have a baseline Pearl, I do think we can safely say that this is someone who has evidence of chronic compartmentalized inflammation. And obviously there will be a degree of that. Cells as well, it's just that you can't determine a cell on a baseline scan. You would have to technically follow that individual, ideally at least over a year. The issue, as you know as well, is cells and pearls don't have great overlap, but people who have cells and pearls do seem to be the ones that progress the most. So with all the imperfections of any imaging measure, I think using a combination of these things will be useful for us to determine whether somebody does indeed have evidence of chronic compartmentalized inflammation, regardless of what their current subtype is.
Fred, I might extend that, I agree completely, is that it's important to note that the findings in the Hercules and Gemini are not that those pearls go away. It's just that when you have pearls, it establishes the presence of something, which may be the pearls themselves or not, right? So I understand your question. It may well not be the pearls themselves that are driving that epoch of progression subsequently, but they mark the presence of a biology that seems to be responsive uniquely to this treatment.
Yeah. Okay, I have one last question for Jiwan, and then we'll take our break. And that comes from the things here. Can we expect AI to help us with these distinctions?
Absolutely. There's already AI-driven automated algorithms to detect central veins. And there was one study in one of the earlier algorithms that showed that the average radiologist required 30 minutes to go through a scan to, use the 40% threshold, not select 6 for central veins, whereas the AI algorithm was able to do it in 3 seconds. So very clearly there's a time-saving component, so long as the algorithms are trained properly. Similarly for pearls as well, it is somewhat labor-intensive to, go through the sequences to detect and to make sure that all of the criteria are met. And even for simple things like lesion detection, as you all know, an automated component of this can be greatly time savings. And our radiologists actually don't use AI, but they just use a simple kind of superimposition of one scan on another. And recently at ECTRIMS, they presented this study looking at missed radiological activity. So the algorithm detected the new lesion while the radiologist did not. And the missed radiological disease activity was also greatly predictive of relapses and progression over time. So I think there really is a role for AI in various aspects of image interpretation in MS.
Okay, my thanks to the panel very much. We'll take 15 minutes for a break.
How many minutes?
15 minutes. 1-5. right, we're going to get started again. So this should be fun. We're going to have a debate, and the debate is all MS progressive? And we have a no and a yes. The rules of the debate are that each person gets 10 to 15 minutes to present their case, and then 5 minutes for rebuttal, and then we're going to vote. And so we're going to start with Professor Antonato, who's going to argue that all MS is progressive. No. Daniel?
All right, so thank you so much, Fred, for the very kind introduction. And yes, I have been asked to debate, is all MS progressive? Take the no position. These are my disclosures, which aren't particularly relevant to the topics I'm going to be discussing today. And I am going to, over the next 15 minutes, show through both examples and some data why multiple sclerosis cannot be labeled as progressive throughout the entire disease course. Start off with a quick case example, and then we will be thinking about biology rather than labels, talk about evidence of MS without any symptoms, specifically radiologically isolated syndrome, talk about evidence of MS without any disease accumulation in all forms of multiple sclerosis, and then look at a little bit of evidence of clinical disability in progressive MS trials to demonstrate that even in progressive MS trials, there is not always progression. And then finally, some conclusions and integration into the new disease framework. So case number one, I'm going to make this a little bit interactive. A 30-year-old woman, long-distance runner, presented with vision loss in the right eye. This was one of my patients. She had pain on lateral eye movements and color desaturation. Her exam had a visual acuity of 20/30, but was otherwise normal. MRI brain, cervical, and thoracic spine were completed. A lumbar puncture was completed, which showed oligoclonal bands, and serum workup excluded other medical conditions. She was treated with steroids and had full recovery, including recovery of low contrast letter acuity. This is her MRI. So you can see here the presence of one periventricular lesion, one juxtacortical lesion, and basically that is it. So let's do a show of hands. Who would say that this individual has progressive MS? Pretty convincing. This patient was started on oral disease-modifying therapy. She remained relapse-free with no accumulation of disease activity on MRI. She suspended treatment twice for pregnancy and promptly reinitiated. At age 40, she denies any types of symptoms or limitations in any aspect of her life. She has a normal neurological exam. This is a patient that I recently saw in Cleveland. Once again, I will ask the audience, who in this room would classify this individual as progressive MS? All right. So let's fast forward to when this patient is 60. I haven't seen her, of course. This is just somewhat of predicting the future. At age 60, she starts noticing some mild memory complaints that are not noticed by anyone but the patient. No longer runs, but she has taken up swimming and is walking independently. She denies any focal weakness or sensory symptoms. Her neurological exam is normal, and she reports her symptoms as comparable to her peers. So here, who here thinks this person has progressive MS? Show of hands. All right, so now we see a couple because she has some progressive symptoms. To counter that, I am going to show you this, which is progression independent of multiple sclerosis. This was a study that was published in 2023 that demonstrated that individuals without multiple sclerosis, if followed over time, do have worsening on the expanded disability status scale. And I would question that this patient probably fits the same as one of the healthy controls, therefore not progressive. This is the classical disease description characteristics. This was already touched upon by Fred, of course. And as you can see here, these 4 labels of multiple sclerosis is what we've historically used to classify the disease. But we are understanding, mainly from what our patients tell us, is that multiple sclerosis should not be a label, and that once somebody has a certain condition, they should not be called progressive for the entirety of that disease. Rather, we're thinking about multiple sclerosis as a single disease that goes through phases or stages or epochs where retrospectively one evaluates the patient and determines, do they have presence of worsening disability progression, neurodegeneration biology perhaps on the one side, and on the other side perhaps relapse biology. Certainly, this has been done with rich phenotypic data. This slide has also already been shown once. This was the No-MS cohort, which was a very large number of individuals from Novartis clinical trials, and they modeled where these patients or how these patients were accumulating disease activity. And you can see that in blue, those circles represent what is called early evolving multiple sclerosis. This is the No-MS database, this is the Roche MS database, and then finally this was validated in the MS Paths database. A lot of this data actually came from Cleveland. And then there were these kind of classifications of advanced MS. And interestingly, for patients to go from the early evolving into the advanced MS, they had to go through an inflammatory stage, either from asymptomatic disease activity or relapse activity. So at least this data-driven approach shows us that perhaps it's not progression that's getting these people to the later stages of MS, but actually inflammatory. One of the long-cited arguments for why multiple sclerosis is not always progressive is actually the finding of asymptomatic MS at autopsy. Georgi in 1961 found incidental findings of multiple sclerosis on autopsy. A noteworthy rate of 18% of postmortem MS was actually asymptomatic. Gilbert in 1983, 5 cases among 2,500 autopsies. And then the Danish registry, Engel, in 1986, found that 25% of deceased persons with an in vivo diagnosis of MS actually probably did not have any symptoms. So this suggests that if the disease was truly progressive in all patients, these individuals would not show up with asymptomatic MS at the time of autopsy. Let's also talk about how radiologically isolated syndrome, asymptomatic MS, can now also be called MS. And I call to this data because when you look at these patients approximately 10 years after their diagnosis of radiologically isolated syndrome, so a large proportion of those individuals actually will have multiple sclerosis now on the new 2024 criteria. Many of those patients do not even have a first clinical attack, and therefore they look very much like the patient in the first case, even earlier to that. So no clinical attacks, 51% of patients. So to call all patients progressive, if after 10 years of biologically knowing the disease happens, to me seems like a little bit of a stretch. Multiple sclerosis severity scale, and this is data that followed patients over several years, up to 30 years, and demonstrated based in deciles that there was a proportion of patients in the first and second decile, so that's up to 20% of patients, who were followed out to 30 years, had EDSSs below 2.5. And this is low levels of disability. We're talking about 30 years out, suggesting that these patients are unlikely to progress. Similarly, the New York State data showed minimal disability at 10 to 15 years. 19.8% of patients had an EDSS lower than 2 at 10 years. 20% of patients had an EDSS below 3 at 15 years. And then finally, approximately 33% of patients had an EDSS below 3, but a disease duration greater than 10 years. So I'm not saying that progression is not common in MS. It certainly is. But there is a proportion of individuals who actually do not progress. And then now let's ask ourselves, is all MS progressive? Well, let's look at MS progressive clinical trials. And so let's start out with the effects of siponimod in secondary progressive multiple sclerosis. Approximately 50% of patients followed over 42 months had no disability progression. One looks at more recent data, the Tolobrutinib Hercules trial. You can see that patients followed over a total of 45 months. Approximately 60% of patients had no disability progression. One looks at the MS STAT trial, followed over 4 years. No progression, approximately 50% of individuals. Ocrelizumab phase 3 primary progressive trial, approximately 50% of individuals did not have confirmed disability progression confirmed at 12 weeks after 216 weeks of follow-up. Clearly demonstrated that for periods of time, these individuals do not have progression. And one might say, well, this is EDSS-based, and the EDSS is relatively insensitive to other features. And this is a study that was presented by Gavin himself, the OHAN study, where it was a combined primary endpoint of either confirmed disability progression on the EDSS or the 9-hole peg test. And you can see that even when enriching with the 9-hole peg test, you can see that it's also slightly over 55% of patients who have no disability progression when followed over 144 weeks. This data was already presented once by Fred and others, and you can see here the box in gray is the one that is determining the number of individuals who have progression in clinical trials. And so you can see these boxes is only 7.2% in RRMS, 19.9 in SPMS, and even in primary progressive MS, it's only between 32 and 33%, therefore low numbers. We might talk about this idea of PIRA, and this was touched upon. The percentage of patients with PIRA in different cohorts is variable and is overall low. So it's typically less than a quarter of patients who show PIRA. So there are a proportion of individuals who are not progressing. This is a recent analysis of primary progressive patients. This was a Bayesian approach that looked at modeling disability progression, and you can see that this follows a Gaussian distribution. There is a small number of individuals that being followed over time were individuals who had low likelihood or were called slow progressors. And the idea here is that progression occurs like almost any other biological variable. It is a normal distribution. There are individuals on the tail ends that do not have progression. This was a study that was conducted by the group of Bruce Taylor, which was associating the presence of a genetic predicting model based on SNPs of both disability and relapses. And very interestingly, what this data shows is that early in the disease, within the first 2.5 years of MS onset, actually what predicted disability worsening was actually the presence of relapses, not the presence of either SNPs or the progression of progressive disability accumulation. Therefore showing that at least in early phases of the disease, probably progression is not a huge determinant of accumulation of disability over time. Data from the CIS cohort in Barcelona. You can see here patients that were followed after a first event over 25 years. You can also see that there was a substantial number of patients after 25 years after their first attack did not have any type of disability progression as measured on the EDSS. So how do we think about this in terms of kind of disease evolution and a new framework thinking about disease phenotypes? I think previously we thought about these labels that we assigned to patients that were fixed. We called a person relapsing or remitting. After 10 to 15 years, we labeled them as secondary progressive, or we called them primary progressive from onset. But when you speak to patients, they will clearly tell you that this is not necessarily the case, that they go through different stages. And perhaps a more modern way of thinking of the disease is thinking about a new framework where a presentation may be clinical, or a presentation may be based on imaging. In the case of RIS, we still don't have a fluid-based presentation, but perhaps that will be possible one day. And then we have two large components of the disease. One is relapse biology. The other one I call progression biology, but you also might want to call that neurodegeneration biology or chronic inflammation biology. And there's clinical correlates of each, relapses and relapse-associated worsening and relapse biology, and in progression biology, PIRA, PIRMA, and then we have imaging markers of each of these. And the idea here is that these states are fluid. These are not fixed states. This is a slide that I took from Tim Kutzi and was also already presented. And in this new model of clinical expression of multiple sclerosis, as you can see, patients go through periods of stability, periods of worsening, which may be worsening associated with relapses, probably earlier in the disease, and then worsening related to either PIRA or PIRA independent of inflammatory disease activity, something called PIA. But the idea that multiple sclerosis does not have fixed labels and cannot be called progression at all times. So in conclusions, progression is a state rather than a label applied continuously. MS, I have shown based on a myriad of evidence, is not always progressive. Autopsy data, RIS data, long-term disability data, clinical trial data in progressive MS demonstrate that a proportion of individuals with biological multiple sclerosis have time periods which are completely devoid of progression. And I think, and I echo Professor Comey, saying labeling young, asymptomatic, or minimally symptomatic individuals as progressive MS is not only incorrect, but it is also harmful. Words carry connotations, and progressive MS has a connotation for people with MS, which we should avoid. We should focus on measuring biological processes that we can address in trials and avoid broad labels. With this, I will thank and hand over to Gavin.
Thank you, Daniel. And now for the opposite, that all MS is progressive, Professor Giovannoni.
Thanks, Fred. Okay, previous slide. I'd just like to remind the audience that depending how you view the world, that life is a sexually transmitted, progressive neurodegenerative disease with 100% mortality. Just remember that. So if that is a true definition of life, then everybody with multiple sclerosis has a progressive disease. Okay. So these are my disclosures. So I think MS is a disease, not a syndrome, and I haven't got time to dwell on that. I just want to remind the audience that our clinical phenotypes were never based on biology. Back in the late 80s, Berlex and Chiron had a meeting with the FDA, and the strict reason for that meeting was to make multiple sclerosis an orphan disease. And the only way they could get 200,000 people to have the disease was to divide it up into 3 diseases. And subsequently, they added a 4th one called CIS. And this was just done for business reasons. And as you know, interferon beta got licensed in the United States as under the Orphan Drug Act. And when you actually go down into the phenotypes, they are one disease. There's no difference in terms of genetics, familial clustering, MRI findings, CSF analysis, etc. There are some subtle differences in terms of treatment response. Primary progressive disease didn't respond to fingolimod, and SPMS responded to siponimod. And there is an age difference with primary progressive disease presenting about 10 years later. And I suspect that's because they missed out on the relapsing phase of the disease. So I think MS is definitely one disease, not 2 diseases, and that's important. So when does progression or worsening begin? I don't like the term progression, but worsening begin. And we now know that even when you do suppress relapses with our most effective therapies, most of the worsening that occurs is independent of ongoing relapses. So this is the post-marketing top study from the natalizumab in Europe, just showing you that the majority of worsening that occurs on natalizumab, and most of these patients are rendered relapse-free, is from PIRA. And similarly, in the post-hoc analysis of the OPERA-1 and OPERA-2 ocrelizumab versus REBIF trials, we saw the same thing. Even on interferon, the majority of worsening was PIRA, and with ocrelizumab, it's almost 90% is related to progression independent of relapse activity. So the important thing to know is if you want to look at brain volume loss, which we know is accelerated compared to normal people, that's a fact of life. From about 35, you're losing your brain volume at a relatively constant rate, and people with MS are losing at about 2 to 7 times faster. And if you think about brain volume loss as the integrator of this end organ damage that underlies the pathology of worsening MS, it occurs at all stages of the disease. So this is the Magnum's data just showing you even in CIS and relapsing remitting patients, they're losing brain volume at a similar loss rate. And if you add risk patients from the Italian cohort, it's very similar. So the underlying pathology that's driving the worsening is there from the very beginning of the disease. And the reason why people with radiologically isolated syndrome and early relapsing disease don't have obvious clinical worsening is because they compensate for the damage. They have enough reserve or resilience not to see that. And so you've got to look for it. So you could put people on a treadmill. So this is work from Don Mahad's group, taking people with really low EDSS scores, 2 or lower, and you put them on a treadmill and you find abnormalities that come out. And if you do these serially, these people are not moving on their EDSS, but their deficits that are detected with stress tests are clearly getting worse. And this brings to mind that we should be treating multiple sclerosis like cardiologists look after the heart. You would never pass a heart off as normal without doing a stress test. And I think we should do the same with MS. We shouldn't view MS through the blinkers of the EDSS. We should be actually doing stress tests. And just to give you an example, if you put people with radiologically isolated syndrome through a cognitive battery, you find they have cognitive deficits they're not aware of, but they're as bad as people who've been given a label of relapsing MS. So you just got to look for the deficits beyond the EDSS. Similarly, if you do some very fine motor tasks, this is the Clever Glove that is done in Genoa, and you take people with radiologically isolated syndrome and you ask them to do fine motor tasks, you pick up deficits they're not aware of. So, and these deficits are progressive, will worsen if you do this serially. So we can detect worsening disability beyond the EDSS, and so if somebody's EDSS is stable, that doesn't mean to say they're not worsening. So in terms of when does this process begin, I think it begins right in the very beginning, but you just have to look for it. Okay? And that's something, so when you talk about those stable EDSS scores, I'm not going to buy it, because the EDSS is not good enough at detecting subtle change. So then I come to this concept of the real MS. I want to point this out, that most of us view multiple sclerosis through a clinical MRI lens. And I don't think that's right, because when you actually look at the 15-year, and this is from the Cleveland Clinic, 15-year follow-up of the AVONEX pivotal trial, strikingly, the people who were on interferon in the trial and had MRI activity or relapses ended up in the worst quartile of outcome in terms of disability and brain volume loss, where those on placebo who had activity didn't. And this is a really important message, because this is saying to you that MRI and activity and relapses is not multiple sclerosis, because if it was MS, if that was the disease, it should predict outcome in both groups. And I won't go through the philosophy and the logic behind this, but I would urge you to read the Prentice criteria and why relapses and focal MRI activity is not MS. Okay? And this has been reproduced in other data sets. It's not unique to that. This is the MS base. There's 2 cohorts, not with MRI, but this is just relapses. When you have relapses on treatment, it predicts outcome, but off treatment, there is no prediction of outcome. So relapses cannot be a surrogate endpoint for the disease, and nor can focal MRI activity be for the disease. So MS is not relapses or focal MRI activity, something else. And so this brings up an old theory that I presented. Actually, I presented this at a European Schalke Foundation meeting in Lausanne, and I don't know when it was either 2002 or 2003, and John Carlo made us write an article about our presentations, and I put forward MS phenotypes as being like leprosy. You have the disease, which is driven by the bacteria, and it's the immune response to the disease that is the clinical phenotype. So if you've got primary progressive disease, you've got lepromatous leprosy, and if you've got relapsing disease, you've got tuberculosis leprosy, and you have the intermediate phenotypes in between. And so I view MS from a clinical phenotype as being dictated by the immune response to what's causing the disease. So there's something else in the brain. And the phenotype is dictated by the inflammatory response to the disease. And you can move people from one side to the other. So, for example, if you take somebody who's got active relapsing disease and you put them on natalizumab or ocrelizumab, an anti-CD20 therapy, you remove the relapses and the MRI activity, and you expose the disease, PIRA. So you move them to becoming primary progressive. And similarly, if you take people with chronic progressive disease, this would be non-relapsing SPMS or primary progressive, and you put them on an immune stimulant, gamma interferon, and this experiment was done in the late 80s, and Hillel Panich published this. These people go on to have relapses. So you can move them the opposite way. And similarly, if you put people who've got primary or non-relapsing second progressive disease on fingolimod or natalizumab, and you think it doesn't work, and then you stop those drugs, you actually cause them to have relapses. So we saw that in our population of patients. About a quarter of patients in the ASCEND, non-relapsing second progressive trial, who were on natalizumab when it stopped, went on to have quite bad rebound. And similarly, there was a group of patients in the fingolimod primary progressive trial. When we stopped the fingolimod, they became relapsing. So I just want to remind people that you can move people along the spectrum based on how you manipulate the immune system. So I agree with you, there is a caveat. So I think MS is caused by Epstein-Barr virus, and I think it's driving the disease. So clearly, if you've got MS and you cure yourself of that agent, then you could potentially stop yourself getting worse. And so the potential cures are people treated with alemtuzumab, and you can see that a proportion of patients go into long-term remission without relapses, and they have no MRI activity, and they start losing brain volume at a rate that's in the normal range. So you've got to ask yourself the question, are these people cured? And we see a similar thing with HSCT. Okay? So there are people who I think we can render worsening free based on curing them of the disease. So that is the caveat. So there are exceptions to the rule, and I was going to remind people the exceptions to the rule is, again, there are about 25% of people who have MS at post-mortem never get the disease. And similarly, in sibling studies, about a quarter of patients who, so if you take brothers and sisters of people with MS and scan them, about 1 in 10 of them will have lesions on MRI scan that looks like MS, and about a third of them actually have oligoclonal bands. But only a small number of them go on to develop MS. So something happens to those people that stops them developing MS. And we can see across the spectrum of the disease, there will be groups of patients that have MS, but then the disease stops and they don't get worse. And even in more severe disease, I mean, Ian MacDonald always used to say to me about 1 in 10 patients, even with secondary progressive disease, would burn out and remain stable for decades. And the question you've got to ask yourself, has those people still got the disease? Have they spontaneously cured themselves? Because if they had the disease, they would still be getting worse. That would be my answer to the question. So one of the caveat is obviously if you cure yourself for what's driving the disease, clearly you will have a treatment-induced or a spontaneous cure. And in that population, they probably won't get worse, even if you interrogate them with those sensitive biomarkers I was talking about. So yes, so I think the real MS is what I call smoldering disease. If you look for it, you'll find it. And that happens whether or not you have superimposed relapses or MRI activity. However, there are some small groups of people with biological disease, as defined at post-mortem, who won't get worse, and I think they've spontaneously cured themselves of the disease, and that's why we need to interrogate them from an etiological perspective rather than using the EDSS. So I'd like to thank you there, and I'll take questions.
A true 5 minutes.
True 5
True 5 minutes response, and then Gavin will be true 5 minute rebuttal.
All right. So, I think there's several things that Gavin said that we agree on, which I think is good. And the first thing is that multiple sclerosis is a single disease. I think we kind of can agree on that. And then the second thing that we agreed on is the postmortem data, which suggests that people who biologically on autopsy had multiple sclerosis, if you go back in time and look to see if they've developed MS, if they haven't had symptoms of multiple sclerosis, well, for me, that's the definition of a person who is not progressing. Gavin has related that to a cure for MS, which might be true, but if they are cured of having MS without any specific treatment or maybe with some treatment, does that mean we have removed MS biologically from those patients? And if we do not remove them biologically because their brains have evidence of multiple sclerosis, that would suggest that the disease basically is not progressive at that stage. However, you might want to get to it. Gavin did present some data that showed very nicely that the majority of patients in trials of anti-inflammatory medications actually accumulate disability through a progressive component. And I am not doubting that in the least. But if you look at the overall percentage of individuals who have progression, it's actually a small proportion compared to the people who don't have progression, at least in the context of those 2 years of a trial. Now, you might say that if you follow a patient over 50 years, those rates, of course, would increase. And I don't debate that. But what I do debate is the fact that this is a disease that is in an evolution process. It goes through states, and therefore calling somebody progressive as a label, every single person with MS, once again, I think is probably incorrect. Now, there is some data, which is a treatment response data, and then Gavin presented this data from the Cleveland Clinic, which demonstrated that individuals who had presence of inflammatory disease activity despite the presence of an anti-inflammatory medication are the individuals that were at highest risk of progressing. There's similar data that was published by Prosperini, which showed that individuals with radiological disease activity are the ones that had the highest likelihood of proportion of individuals who are going on to develop secondary progressive MS. And the interpretation from that data is different what Gavin presented to what I present, which is in an individual who has an anti-inflammatory agent on board, who breaks through that effect, is indicating an individual who has inflammatory disease activity that is portending a high risk of progression over time. So it's like you're selecting individuals who have a lot of disease inflammation, and the downstream consequence of that inflammation, of course, in the future is going to be progressive. Gavin used the term smoldering MS, which is a term that I particularly don't like. It's pathologically not specific. It doesn't have a clear meaning. And I think we should avoid labels for people with MS. Gavin mentioned lepromatous and tuberculoid multiple sclerosis. Those are probably terms that I think people with MS would not probably appreciate. And I would describe individuals and the biological processes that are in front of me. Let's describe what we can. Let's develop treatments for what we see in terms of the biology of the disease. And eventually, our common goal is to get everybody to a cure. Thank you.
5 minutes?
5 minutes, okay. Yes, I mean, I'm just going to go back to, so the reason why I use the leprosy analogy is just because the cause of the disease is the same, but the phenotype is dictated by the immune response. So all I'm saying is our clinical phenotype is based on the immune response to what's causing the disease. And so I've been convinced for decades, based on causation theory, that our disease is driven by, disease is caused by EBV, and there's now increasing evidence that the virus being active is driving the disease. So EBV is the driver. And if we take out EBV using antivirals or an immunotherapy, then we remove the stimulus, and so the disease is cured. Okay. And I use HSCT and alemtuzumab as examples because I think that's an immunotherapy. We're rebooting the T-cell compartment and we're giving them a vaccine with their own virus, and they control the virus after the procedure. And, well, not all of them, but the majority of them control the virus. So I'm just using this as an analogy with an infectious disease to explain what I mean by lepromatous and tuberculoid leprosy. It's just an hypothesis. Okay. But the reason why I say that, though, is because we as a community define our disease by relapses and MRI activity, to be honest with you. Most people define, and now with the new criteria, you can't have the disease without an abnormal MRI scan. So, even if you present with a progressive myelopathy, for example, with ill-defined lesions, you can't have the disease until you have an abnormal MRI. So our definition of the disease is still very focused on a clinico-radiological construct, and I think MS is a biological disease. We may even be able to diagnose the disease in the phase before they even have focal lesions in the future. I predict we will, actually. We'll probably get an immunological phenotype that predates focal lesions, and so we can move the disease even further forward, the definition further forward. So I think we have to shift our worldview away from MRIs, focal lesions, relapses, and EDSS particularly, and start thinking about what's happening in the brain that's causing the immune response to that stimulus. And then the reason why I've got a caveat is simply because if you cure a disease, you'll hopefully stop them getting worse. But the people who are not cured will get worse, and you've just got to look for it. So if I can just say in conclusion then, everybody who's got the pathogenic driver of the disease and haven't been cured from that, be it spontaneous or via treatment, will have worsening if you look for it carefully. And therefore, everybody with multiple sclerosis has a progressive disease because the process is still ongoing. And don't be fooled by the clinical and MRI scans if they're not detecting any activity that patient doesn't have worsening. If you look for it, you'll find it. So that's why I think everybody who has MS has a worsening process underlying the pathogenesis of the disease.
Thank you very much. Would you guys turn your chairs around?
Towards our...
Face the screen. Okay. This is how you vote anonymously, at least from the speakers. So you've heard the debate, And now, can we turn the lights up a bit so I can see? Is that doable? Okay, so apparently not. Okay, so we're going to vote. So first question, is all MS progressive? Yes. Please raise your hands. Okay, this is hard. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. Okay, I've got it. All as progressive, no. Raise your hands. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Okay. I've got it. It's actually too close to call. I have to say, just because the lights aren't on, it was pretty close, but I think the no's probably won, but I'm not going to call it official, just because I couldn't get the lights on to be sure. But it was certainly a lovely debate, and I think we should applaud both of them. Okay, moving on, we're going to talk about overall treatment strategy from Professor Montalban, who is the chair of the Department of Neurology and Neuroimmunology and director of the Multiple Sclerosis Center of Catalonia. Xavier.
So, good afternoon, ladies and gentlemen. Thank you very much, Fred, for inviting me to be here. If I may, I vote no now. It's not progressive. It's very lucky that in Spanish or in Catalan we don't have a translation for smoldering. I'm very happy about that. And then after 35 years and seeing patients, I saw definitely patients with no progression. So thank you. I will be talking about the overall treatment strategy for multiple sclerosis. This is my disclaimer slide. I have all the conflict of interest for this topic, to be honest with you. And this is the, Amit also showed this slide, just indicating that nowadays we are close to know the cause of multiple sclerosis. We know a lot about genetics, we know a lot about the environmental factors, specifically EBV infection, but also vitamin D, smoking, etc. Epigenetics is playing a very important factor, a very important role as well. And also, we know very well the mechanisms of disease, and we know how to identify some of them by using MRI, by using OCT, PET scan, biological biomarkers. So, and also, and this has been repeated here on a number of occasions, we now consider that there is one single disease. The mechanisms of disease are the same, with different intensities over time. And of course, you have here the mechanisms of disease. We know that at the earliest stage of the disease, the focal acute inflammatory activity predominates. And then in later stages, the compartmentalized chronic inflammatory activity with axonal loss and neurodegeneration predominates. But both components are at the early and late stages of the disease. So if we have to talk about treatment, the first thing we can do, the very simple, let me say, if I find, here it is just go to the modifiers that we have in the disease, producing different clinical expression, different degree of relapses or disability accumulation. For instance, comorbidities, for sure, the use or not of disease-modifying therapies, health behaviors, just to give you one example. We also know that, I don't know how to do this, yes, that we have an optimal therapeutic window at the earliest stage of the disease, mainly if we use high-efficacy therapy, and we will be talking a little bit about this. So there is a huge amount of evidence indicating that early treatment, a high-efficacy treatment, produces a long-term benefit in our patients, a better prognosis, and also that early and accurate diagnosis favors the early onset of treatment in our patients. And with the 2024 criteria that Fred explained to us, I think we have to go one step forward. And let me just share with you again this paper presented by Luca Bolo from our center at the last ECTRIMS in Barcelona. And what he found is a 42% relative percentage increase when comparing 24 against 27. He found as well that McDonald's 24 anticipates the diagnosis by 6 months, which is not trivial, in relation to the treatment response, and also that no patients met the 2017 criteria without also meeting the 2024 revision. So I think this is quite a remarkable paper. So then we want to personalize the treatment as much as possible, and we have quite a number of options nowadays, and here you have the list. And they have different mechanisms of action, as you can see in this excellent review by my colleague and president, Hans-Peter Hartung. And then probably, well, we do have very high efficacy therapy medications that we consider in our center monoclonal antibodies. We have high efficacy therapy, cladribine S1P modulators, and then we have moderate efficacy therapy, just to be kind. And this could be a very simple treatment algorithm. So you don't have any poor prognostic factor, and then you can use, in some countries, injectables. I have to say that we don't use interference anymore. Very occasionally, glatiramer acetate. Perhaps you would like to use, in these very mild patients, teriflunomide or dimethyl fumarate. When the patient have poor prognostic factors, you may use high efficacy therapy such as S1P modulators or cladribine, or very high efficacy therapy, all the monoclonal antibodies, the anti-CD20, natalizumab, and alemtuzumab. Remember as well, and I wanted to introduce this slide here, that the World Health Organization, for the first time in 2023, included disease-modifying therapies for MS in the model list of essential medicines. And they are glatiramer acetate, cladribine, and rituximab. And I think this is very important, and we have to remember this. Not all countries have the same access to medications. Another typical question is this one. So is high efficacy and early treatment beneficial for our patients? The answer is yes, of course. Plenty of evidence, plenty of papers indicating that. And let me just here show this slide of our esteemed colleague and friend Giancarlo Comi when he was a little bit younger, right? I remember him. He was the one defending the early treatment of MS when the first betaferon or betaseron appeared, and I remember him fighting in the ECTRIMS with his Italian English as bad as my Spanish English, and he was very much convinced, and he was right. Just to say something about him for this. So I'm going to show you one single paper, which is, I think, the most recent one, coming from the Italian MS Society or the Italian MS Registry. And they were able to study quite a number of patients, and they, using propensity score matching, at the end they had 900 patients in the early intensive group, and also 900 patients in the escalation approach. And the early intensive treated patients did better for all outcomes, confirmed disability accumulation, PIRA or RAW. So the last proof that early intensive or high efficacy therapy from the early stages of the disease is better than the escalation approach. So what about the treatment response? We are talking about treatment, we're talking about high efficacy early, but we have to monitor the treatment response, otherwise there is no sense. And I think that there are many, many papers on this, as you know, but I would say that the NIDA is what we are looking for our patients treated with whatever. That's why we repeat the MRI every year. That's why we follow up our patients whatever in our center every 6 months, sometimes every year. But be careful. This paper was presented at the last ACTRIMS as well, coming from our center. So patients with NIDA3 at year 1 and with high levels of neurofilaments lose their NIDA3 status at year 2. So this is not so easy sometimes, and in relation to the use of biological biomarkers, I think in the treatment response, mainly in those patients who have been treated with high efficacy therapy and still neurofilaments are not down, could be useful. Okay, so there are unmet needs still, despite an increase of MS therapies. We know this. Gavin and Danny showed that even patients with a very powerful anti-inflammatory drugs, such as anti-CD20 and natalizumab, they do progress, and this is real. But recently we learned, and I think Ludwig will be talking about this, so I'm going to show just 2 or 3 slides, Ludwig, no, don't worry about that, that using tolebrutinib, the Hercules trial on non-relapsing SPMS against placebo, and then the Gemini 1 and 2, tolebrutinib versus teriflunomide in relapsing MS patients. The Hercules trial was positive with a 31% risk reduction. That was quite interesting and really very welcome. But also, I think the Gemini that was failed trial in theory, I wouldn't say fail. The Gemini was not a failed trial. Gemini didn't reach the primary endpoint, that was annualized relapse rate, and as you can see here, teleflunomide and teriflunomide behave the same for annualized relapse rate. And however, the main secondary endpoint, time to onset of 6 months confirmed disability worsening and 3 months confirmed disability worsening, that was statistically significant. And I think this is the first time that happens. I can't remember any trial not being able to decrease the annualized relapse rate, but being positive in the confirmed disability worsening. So I wouldn't call this trial negative, very informative. And of course, just 2 days ago, we were very happy when we learned that the FENhance 2 using fenebrutinib in relapsing MS patients against teriflunomide met its primary endpoint, so less relapses compared to teriflunomide. And I was a little bit skeptical because taking into account the very low rate of annualized relapse rate in the teriflunomide arms, I thought that this was now going to be positive, but has been positive. I don't know the numbers. Perhaps Ludwig knows, but I don't know the numbers, but it is positive. So, and also the very good news is that fenebrutinib it was as effective as ocrelizumab to deal with disability progression in primary progressive MS. It's numerically superior, but not statistically superior. And I have to say that that was even a bigger surprise to me, because that was a very brave trial, fenebrutinib against ocrelizumab. And so I think this is very good news for the whole MS community. Let's wait for the FENhance 1 result and also to see the numbers. This is where we are now. I think we want to know as soon as possible the Perseus results, tolebrutinib versus placebo in PPMS. That would be very good. Still, remibrutinib is going on, and there are other in phase 2 trial, in phase 2 phases. Switch to another very interesting drug, CD40 ligand, blocking that the CD40 ligand, frexalimab. Quite impressive results in the phase 2 trial, as you can see here. Quite a an important decrease of the gadolinium-enhancing lesions, and now, I don't have the slide here, but there are 2 phase 3 trials in relapsing MS and 1 in non-relapsing SPMS with this molecule. And this molecule pretends to be more or less equally effective in reducing the focal acute inflammatory activity and more effective in reducing the chronic compartmentalized inflammatory activity and therefore disability progression with a higher degree of safety. Let's see how it goes. And then the CAR-T, of course, we now are running 3 or 4 CAR-T trials, phase 1 trials in multiple sclerosis. A very appealing concept, mechanistically is very attractive. So let's see how it goes. Up to now, the few patients treated with this molecule, anti-CD19 CAR-T, are doing well. Just 1 side effect, but the rest are doing well. So let's see how it goes. The number of clinical trials of CAR-T cells is increasing year by year. 3, I think that now we have 4 MS trials, but perhaps other people know the exact number better. And I would like to just show 3 or 4 slides about the updated ECTRIMS EAN guidelines on the treatment of multiple sclerosis, which is under review. This is the steering committee, many known names, of course. And just to mention a few things, the first statement is that the DMD should be prescribed by a neurologist with expertise in multiple sclerosis and ready access to the proper infrastructure to provide proper monitoring of patients, comprehensive assessment, and early detection of side effects. Also, that happened in the previous version in 2018, consider starting treatment as early as possible. The difference now being that we recommend choosing a higher efficacy DMD early on. We also state that offer a more efficacious drug to patients with DMDs who show evidence of disease activity, and also that be careful when you stopped high efficacy DMD because you may have problems, so switch to another high efficacy DMD. And this is what we do at ThinkCAD. We have a peculiar way of prescribing at ThinkCAD. We have nobody can prescribe a medication by himself or herself. All the new medications and also switching medications are presented weekly in rounds of 1.5 hours. There are 19, 20 neurologists on site, but also other hospitals connected, the Department of Pharmacy, the Department of Pharmacology, sometimes neuroradiology as well. And then we discuss the case. It's not really very democratic, I have to say, but at the end, many neurologists give their opinion, and we try to identify the best option for that specific patient. And I think this is quite unique in the treatment of multiple sclerosis. And this is what we do. I'm not going to go through this protocol. It's a little bit too colored, but we used mainly high-efficacy therapy, but also sometimes seriflunomide, dimethyl fumarate. I have incorporated here BTK inhibitors for patients who have disability worsening without focal and acute inflammatory activity, but also those who with focal acute inflammatory activity and PIRA, which it's also the same as Fred mentioned, it's just progressive disease. Let's see how it goes with the label for tolebrutinib at the end of this year. Hopefully that will be positive. This is our status in ThinkCAD. This is the percentage of patients with moderate or high or very high efficacy DMT. Moderate, which are injectables and dimethyl fumarate, teriflunomide. This is the blue. Of course, we started with the Vidaseron, Copaxone, etc. And then in this other medium blue, you have the high efficacy. High efficacy means S1P modulators and cladribine, and then the dark blue are very high efficacy. That means monoclonal antibodies. So you see, I think here we started to use cyclophosphamide or something like that, and then mitoxantrone and immediately natalizumab, and this is the peak. And then the PML thing appeared, we decreased the very high efficacy, and suddenly we started again with natalizumab and also with anti-CD20, and we are here. So more than 50% of patients, naive patients, start with very high efficacy therapy in our center. And very few of them start with moderate efficacy therapy. That means injectables, almost none, and oral teriflunomide, dimethyl fumarate. So if we have to talk about treatment, we can't forget this. We can't forget, we have set up a prevention clinic at ThinCAT. So there are a number of professionals taking care of other business apart from treatments. For instance, the smoking thing, the vitamin D levels, the overweight. We don't know how to deal with the microbiota yet. And also remember that there is a paper published this year, I think it's the first one, indicating that very high dose of vitamin D reduces MS disease activity after a CIS in a comparable proportion of interferon beta or all the medications tried in the classical CIS trials. And also that this meta-analysis, recent one, including 21 studies indicating that vitamin D supplementation produces a statistically significant, modest, but statistically significant reductions in disability progression, relapses, and new tissue lesion formation. So I think this is, it's not very expensive, it's not toxic, or very rarely is toxic. Comorbidities in the prevention clinic as well, all the vascular risk factors mainly, and also we take care of the first degree relatives, in the sense that if they don't have to smoke, we provide vitamin D, all these things. And I think this is the last concept. When we are talking about treatment, it's not only about drugs or neurologists. Sometimes neurologists, we are the less important professionals in our MS center, and then social workers or nurses for sure, neuropsychologists, speech therapists, art therapists, occupational therapists, and physiotherapists, they play a key role, at least in our center at ThinCAT. And as you see, in the past, I put the MS patient in the center of the issue. I remember that. And then I presented this slide in a patient meeting, and they complained quite a lot because they don't want to be, they are not the problem. The problem is the disease, MS. And they want to be at the table helping in solving the problem. And I think with this, I thank you very much for your attention. Thank you.
Thank you, Xavier. So to be respectful of people's dinner plans, I'm going to hold questions until the end, and hopefully we'll have some time then. Okay, next we have a special lecture, which is entitled Novel Therapeutic Approaches to Multiple Sclerosis, BTK and Second-Generation Anti-CD40 Therapeutics. This lecture is supported by an educational grant from Sanofi, and is being given by our friend and colleague, Professor Kappos, Professor of Neurology at the University of Basel, and CEO of Research Center of Clinical Neuroimmunology and Neuroscience, also in Basel. Welcome.
So thank you, Fred, for the invitation and also for assigning to me this task, which is, of course, discussing these two or these two treatment concepts is in the focus of our interest, and you saw already some of the results that further triggered our interest in these matters. Of course, there will be some reiteration, but I think you will survive that, and I will keep those parts that are overlapping short. Here my disclosures, no personal benefit regarding income. What do I want to talk about? I will not spare a short introduction and then concentrate on the task and the topic that I was assigned and have been assigned, and then some conclusions. So I think we all agree that, especially with highly effective therapies, we can control and even abrogate in most of our patients' acute disease activity. But also, and this has been reiterated a few times during this course, we understand that there is something else, that progression is something that we encounter already very early in the disease, even before the diagnosis is made, and depends to a large extent on our sensitivity of measuring this progression. You saw that was a certain ambivalence, at least in the participants of this course, that regarding the question, is it something that everyone has, and is it a trait, or is it a disease state? Personally, I'm optimistic, and therefore I still believe that there may be certain patients who don't have progressive elements in their disease. I'm not very confident about that, but at least I know that, and we know, all of us who have been treating people with MS over the years, that there are several patients who out of a progressive phase come to a stable and also long-term stable situation, so that progression is not necessarily, at least from the clinical impression, even if you look more thoroughly to that, not something that is irreversible or cannot be stopped, hopefully more and more by treatments, but also due to other factors that we are not really aware of. So anyway, the current challenge is, and I guess here we agree, all of us, that it is to halt disease progression, and this means to detect it timely and then to better understand the pathogenesis of progressive elements, but also acute inflammatory elements in the disease, and then to assess, to define, to design, and to assess more targeted therapies, which of course have different goals, not only to halt progression, but also to improve, to allow improvement through compensation, perhaps promote repair, regeneration. We will hear more about that during this course. What we also all know is that the drugs that we are currently using that have been approved have their effect, their proven effect, in the periphery, not in the central nervous system, especially the highly effective treatments. Monoclonal antibodies do not significantly pass through the barrier, and you will hear more about that with cellular therapies that, as an example of a strategy that tries to circumvent that. Another aspect that has also been alluded to is the definition of the disease and the different disease causes, which is dependent, and Gavin made the point very clearly, perhaps too clearly, that this definition between, or the separation between relapsing MS, SPMS, progressive, secondary progressive and primary progressive MS was led by issues with approval of drugs. I would see that more positively, At the beginning, we thought that that progression is something that we can address also with these days first-line therapies, and that it was more a matter of looking at those patients where progression occurs, is measurable, and this was secondary progressive, perhaps primary progressive MS. And we saw that this was not the case. There were very small exceptions, perhaps with the European SPMS study, but in general, the results were negative. And so in this situation, it was clear that we want a treatment for MS. It can benefit part of the population, and therefore this separation was important and was also supported by both us as neurologists and people involved in the management of patients with MS and the regulators. And then it was with the approval of Siponimod in 2019 that the FDA was not so conservative as it usually looks. And in order to accommodate the evidence for this new drug, put all the relapsing patients from CIS to a part of the secondary progressive MS population together in one group. So again, in order to define those where by clinical trials it was shown that this newly approved drug has an effect. And the term of non-active SPMS was introduced also from the regulatory point of view, and in EMA was also in the approval process of drugs introduced active relapsing remitting MS, active secondary progressive MS, and highly active relapsing MS. Nowadays, as we already have discussed, we tend towards the lower part of this graph that we see that progressive elements, mainly PIRA, if it appears also clinically, are visible, and in this way also must be addressed by treatments throughout the disease course. So this was the introduction, and now I discuss two principles where we still have the option to address both parts of the disease pathology, acute and progressive elements, with one therapeutic agent. And the first candidate for that is frexalimab, a second-generation humanized IgG1 monoclonal antibody that targets CD40 ligand on activated T cells, where it is an important co-stimulatory pathway, and also other cells. The important addition to the previous attempt, so why it was taken up again for treating as a potential treatment of MS, was that through Fc engineering it was possible to avoid binding with endothelial cells and to eliminate the thromboembolic risk, at least in the results that are currently there. Of course, the clinical evaluation is ongoing if this really happened, or if there are some patients where this may still be a risk. Up to now, there were no such signals with the second-generation antibodies. There are several findings in experimental models and also in vitro that associate the CD40 ligand pathway with pathogenic events or pathogenic events in multiple sclerosis that are mentioned here. And you see here in the diagram that this pathway is important for the interaction of B and T cells, for the interaction of T cells with macrophages, but also with dendritic cells as shown here, and the induction of cytokines that then shift the repertoire of T cells further on. So the ambition is to address through this double aspect both the acute and the progressive aspects of the disease. And the first study that provided evidence was according to the standard scheme that we have been using since many, many years in order to understand if there is at least an effect on acute inflammation, and then to take this further. There was also, with additional measures in MRI, some evidence, and I will show that. So not only the choice of the dose, but also some evidence that the other aspect, the progressive elements, may also be addressed with this study, but this was designed primarily in order to show the acute effects. So the primary outcome and secondary outcomes of this phase 2 trial was, after 6 months, quite convincing. Perhaps also some and dose-dependent effect on acute disease activity in MRI, but also on relapses. These results have been published some time ago and are well known. More recently, we had the opportunity to see published also the results of the open-label extension, which showed that the effect is quite robust, at least with the higher dose treatment, and stable until week 120, as recently published. You see that in the number of gadolinium-enhancing lesions over time, which looks quite convincing, and stable low. Also enlarging T2 lesions were clearly suppressed over time, and there were some indications that by biomarkers in the blood, plasma NFL and CXCL13 levels over time, that they are also suppressed or lowered. And as expected, no effect on lymphocyte counts, also in the longer term follow-up, no effect on IgG and IgM levels over time, and a rather benign adverse event profile. So over time, in the acute, in the double-blind period, there was no indication of a higher infection rate, but then in the longer-term follow-up with a week 120 cutoff, we see perhaps in this in the right column on the slide, you see that there is a tendency towards more infections over time, but not so clear signal, maybe an initial signal in this. And you see here also more detailed that there was also nearly no liver signal in this population of patients followed up until month 120. This is the basis on which the ongoing studies have been designed and started. Again, the usual program, 2 phase 3 studies in relapsing MS, and you see here again the scheme with a primary outcome annualized relapse rate, adjudicated, but still the same outcome, and on some secondary outcomes that try to capture more of the full spectrum of effects of this compound. The study that, according to the scheme that I showed, that is important for regulators, especially for FDA, but also partly for EMA, there is a phase 3 study, non-relapsing SPMS, the so-called FREVIVA, which has a disability progression, composite disability progression over time as the primary endpoint and a number of secondary endpoints. So we are awaiting these results. One of these studies is still recruiting as far as I understand, but up to now there was no negative signal, and interest in the study seems to be quite high. Now to the second group, BTK inhibition. Again, here there is on one side the expectation of B-cell or an effects on B-cell receptor activated processes, and on the other side a direct effect, especially for those compounds that have easy access to the CNS on CNS microglia. And in this way, not only an anti-inflammatory effect in the CNS through microglia, but perhaps also some effect on the equilibrium. This can be shown in more detail. So as a basic understanding, BTK inhibitors are relatively proximal in the intracellular pathway triggered by the B-cell receptor and also by FC receptors. And you see here the differential effects that are induced through BTKs and then through the blockade in B lymphocytes, in macrophages, and as well as in microglia, in basophils, and in mast cells. For MS, it seems to be most important the effect on these two groups, B lymphocytes and macrophages, microglia. But eventually, perhaps from the literature, that there were some claims that also basophils and mast cells may be implicated, but they're not in the center of our interest. Again, as a central mediating element, this BTK has a central role in the activation and in different cascades, and this is the basis for our expectation that it has an effect. So on one side, you see here on the left side, also from a nice review by Kramer, and Amit was also part of the authorship, that shows these effects mediated by the B-cell receptor and also by the FC receptor gamma that are shown here. I will not go into details in this context. So the expectations, oral agents with a new class of compounds, more reversible B-cell modulation with the added bonus on targeting myeloid cells, and then also in combination with the CNS penetration, an effect on resident B cells and microglia in the CNS. So a direct effect on progression as we understand it now. So what are the compounds that are currently developed in MS, at least in larger programs? I will go into each of them. You see that their molecular structure is quite different in many aspects, but still they were regarded as a class, and we are now, through the clinical investigations, clinical trial results, approaching to an understanding that it makes a difference which BTK inhibitor we are looking at. What are the important features that may be important, that may be interesting and differentiating for the treatment of MS? On one side, it's the binding reversibility and irreversibility. intuitively you would say something that is irreversible is better. You can steer in a better way, so may have less risks. On the other side, of course, it may be also that the inhibitory potency is lower. So again, something that is not so from per se or per definition clear. Then it is the selectivity of BTK inhibitors, the mode of binding, if they are covalent or non-covalent, and then also if they occupy the target completely or not, and then the degree of CNS penetration. You will see that in more detail for those compounds that are currently under investigation. The selectivity would, again, intuitively mean that if these are the right kinases that are selectively addressed or inhibited, that this also decreases potential toxicity. So what data are available? This is perhaps not the very last characterization, but again, from this review paper, you see that the molecular weight is quite similar. The four of these compounds have an irreversible binding, and one has also a reversible non-covalent binding. This is fenebrutinib. The selectivity is also different. You will see also a graph on that with remibrutinib and fenebrutinib having a higher selectivity for BTKs. And the receptor occupancy is difficult to compare across the different compounds because of different methodologies also or measures for that. And again, also these differences may be interesting from the point of view of expectations, but at the end of the day need to be addressed by clinical evidence. Here, just an example that may be more centered around remibrutinib, that at least in this seems to be more selective than the other compounds, as you see here. Also the BTK occupancy in this graph, that was of course also studies that were supported by one of the companies, show a better profile than others, but again, the importance over time has to be shown. And so let's see the clinical, in the clinical situation has to be shown. So let's look at the results in more detail. The first to enter the stage and also with results was evobrutinib. And we all remember the publication and the hopes associated with this publication of the phase 2 study with evobrutinib, where there was an effect on the proof of concept standard outcome, T1 gadolinium positive lesions as compared to placebo. Javier was the first author and the lead investigator for this very important study that, of course, raised the interest in this principle, also with other BTK inhibitors. As you know, phase 3 was unfortunately negative, so it was not against placebo, but against teriflunomide, so there was no superiority as compared to teriflunomide in the effect on acute activity, be it relapses, especially on relapses, also no effect in the combined analysis on confirmed disease progression, no possibility to differentiate the two Kaplan-Meier curves on this graph, as you certainly will agree. One indication that we might really have a different principle of action, although not too weak, to show up or to differentiate itself against teriflunomide were the findings regarding MRI activity. And you see here that specifically T1 gut lesions were different in both trials separately, at least numerically, against evobrutinib. So the T1 gadolinium enhancing lesion numbers were numerically more suppressed by teriflunomide, with a similar effect on disease activity as shown by relapses. The difference was not the same with T2 lesions. Again, stuff for further thought at this stage about the implications for the mode of action. So tolebrutinib, again, the results have been summarized by Javier already, but I think we need to discuss it also under the aspect that it is the first drug that shows that there is really a different mode of action and that this mode of action is relevant for MS. The phase 2 study results showed again an effect on acute disease activity, no question about that. On some MRI markers, there was an indication also of an anti-degenerative effect, but again, not really convincing. These effects were stable over time, so both relapse rates and the low toxicity seen overall were confirmed in the long-term follow-up. In this phase 2 study, also in the long-term follow-up, the liver toxicity that then appeared in the phase 3 study was not a problem, again showing how important it is also from the safety aspect to have these large studies. You see the effect on, it was also a dose-finding study, that the effect that may not have been so impressive overall on acute disease activity was quite good if the 60 milligrams, so the highest dose, was assessed by itself, and for those patients then when they switched to the 60 milligram dose over time. So this again was the basis for the phase 3 trial program, which in addition to what you have seen for frexalimab, includes also a study in primary progressive MS. So the typical or classical relapsing parallel studies, then one in non-relapsing secondary progressive MS, and one study with PPMS patients. You know that the results of the 3 out of these 4 studies have been published in the New England Journal of Medicine earlier this year, and I will just review some key aspects that I think are also conceptually important. The classical design you see on the upper right corner, then you see the efficacy endpoint of the relapsing trials, which was similarly disappointing as the effect that we have already discussed with evobrutinib. So no difference in that, but there was a difference of nearly 30% lower rate of 6-month confirmed disability worsening. It is important to know that we are here in a statistical dilemma. The study, those who conceptualized the study wanted to have the full power for the primary endpoint. I don't understand why, but had a hierarchical design. In this hierarchical design, any other analysis can only show nominal differences and not statistically significant difference. It's difficult for the non-statistician to understand that, and you heard already the interpretation by Xavier, who said this must be something, and I agree, but the formal proof of this effect is difficult. And what was also important in this respect, again, the same phenomenon that we saw with evobrutinib regarding acute inflammatory activity as visualized by gadolinium-enhancing lesions, not as much in the new and enlarging T2 lesions. You see again a lower rate with this standard and medium efficacy, some people say low efficacy treatment with teriflunomide in this respect. Fortunately, at the same time, the disappointment was alleviated by the in parallel communicated results of the Hercules trial in non-relapsing secondary progressive MS, and indeed there was a high number of patients with more than 50% with an EDSS of 6 and more, so needing walking assistance, and also quite advanced in their disease course, or the mean duration since symptom onset was 17 years in both groups, so a very similar, perhaps even more non-relapsing population as in the Siponimod trial. The primary endpoint here was met. There was a significant reduction on the EDSS alone, not the composite disability score. And this is numerically across studies in a similar, perhaps even more advanced population, more than what we had observed with Siponimod, where this reduction was around 20%. So, and using the same measure, the neurostatus EDSS, with several attempts to standardize and to have a measure that is really comparable, and in this case also comparable across studies. So exactly the same method of assessment of the EDSS, and this makes the results, at least for me, even more convincing that this endpoint was met. There are other indications also from the Gemini studies in relapsing MS that the effect on disability progression was real, because we see also a difference numerically with these constraints of statistical analysis regarding improvements. There is some note of caution, because again in a hierarchical design of analysis in this study, the 9-hole peg test was put very high, and all the consecutive analysis in the Hercules trial again only cannot be reported except as nominal differences. This is again regarding disability progression with these constraints is certainly an effect that has been shown, and fortunately, perhaps not to the disappointment of the sponsors and many of us, but fortunately for our concept or the analysis of the concept, the effect on acute inflammatory activity was lower. So this discrepancy is really, for me, the best proof of clinical proof of concept of the expectation that there is a separate and independent effect in comparison to other drugs that we are using in MS. The safety profile was in general quite good, but the liver toxicity led also to restrictions by the health authorities and many additional analyses, and is still not explained why a very low but still important number because of the severity of this adverse event of patients show liver toxicity. This is an unresolved question and up to now, and something that may differ, but the data are not clear enough at the moment, may differ across BTK inhibitors. One further indication, a new way of analysis of such a study was the PRL numbers that showed that those patients who had a higher number of PRLs at baseline had a better effect of the drug, or a more impressive or more visible effect, but again, in both trials, that supports that there is really something behind that. We always have doubts about that if we look at post-hoc analysis, but the stability across trials with this analysis method is certainly something that increases our confidence. The confidence will be, of course, also hopefully supported by decisions of health authorities. FDA has asked for more time and took this time until end of the year, so I hope instead of September we will now know in December, and EMA is projected for very early next year, so we will see if the indication in non-relapsing SPMS will be approved. What about the other candidates? Again, you heard from Javier the most important information in this regard, fenebrutinib. The phase 3 program started in view of the expectations and the urgency before phase 2. But a phase 2 study was added to the program a little bit later after starting the phase 3 program. You see a difference, and I think a good difference to the other programs, except for the classical analysis in relapsing MS. This study where the fenebrutinib is compared to teriflunomide, so the classical scenario. With fentrepid, there was a more brave, but also more, I think, a more meaningful design, where it was compared was compared in primary progressive MS against an active comparator, the only approved drug for this indication with ocrelizumab. And the reasons of the phase 2 study indicates that the effect on acute inflammatory activity is at least as strong, perhaps stronger than what we have seen with the other BTK inhibitors in similar situations, and is also lasting in the longer-term follow-up. The results were recently presented and published, so of this phase 2, later phase 2 study, FENOPTA. One other aspect in these later conducted and now published studies or presented results is that there was also proof in the clinical situation of CSF concentrations of fenebrutinib, so that the access to the CNS was proven in vivo. Again, to the phase 3 program, you all, and Javier has also alluded to that. This is the press release that is now available, that the primary endpoints, in contrast to the other BTK inhibitor studies, also in the relapsing MS, was reached with a significant reduction of the relapse rate as compared to teriflunomide, and also that in comparison with ocrelizumab, it was shown that fenebrutinib is not inferior to that fentrepid or fenebrutinib is not inferior to ocrelizumab in this population of patients. We hope that the results that we can present, the results earlier next year, and that then the positive interpretation by Roche that this may be the drug that can be used throughout the different disease stages or phases and with different causes of the disease if these are further confirmed. The last larger program with BTK is with remibrutinib, where we have 2 studies in the classical design without a study in a progressive disease yet that have a very similar design. I showed also some data or preclinical data that make it or created optimism with Novartis to conduct that and with the investigators involved in these studies. We are awaiting the results somewhere mid or end of the next year. So to conclude, I hope I provided some of the current data that may inform but do not really answer these questions that I've listed here. So is there still I think there is still an option, but up to now, nothing that really confirms that one drug can serve all people with MS across the spectrum. Other possibilities of clinical indication also alluded to by Javier in his presentation. It could be an add-on if under high efficacy treatment we observe PIRA or maybe even a monotherapy in those patients in certain stages who show PIRA, and of course also the question about safety concerns. The only very clean regarding liver enzyme elevations and liver toxicity of the currently assessed BTK inhibitors seems to be the last mentioned, based on studies in other diseases, especially in dermatology, where there was no significant liver toxicity, but this may also have something to do with the dosing, and it must be seen together with the clinical efficacy and of course also with in the MS population if this positive message can be further stabilized. That is the end of my presentation. I want to thank people in our group in Basel, and I'm especially happy that Fred was able to pronounce this difficult name when he introduced me, and of course to thank you for your attention.
Thank you, Ludwig. Moving on, we'll now hear about biosimilars from Professor Friedman, who's the director of the Multiple Sclerosis Research Unit and professor of neurology at the University of Ottawa. Where's Mark? Ah, here he comes.
Thank you, Fred. This is a topic of growing interest as we are moving into an era which I will address a little bit further when I give the lecture on Friday morning when we talk about combination therapies. So with that in mind, I'm just going to run through what we know about biosimilars. These are my disclosures. I think one of the driving forces for this is very clearly the cost of our disease-modifying medications today. Just as an illustration here for you, this is data that has come out of the USA, and you can see the 4 different groups of drugs that have been followed. The estimate was that they would go up 3 or 4% a year, but instead it's surpassed more than 10% a year, and they continue to rise. So the cost of these drugs alone are onerous to anybody who is supporting them. And it was stated some time ago that the generic drugs would be expected to limit the rising costs, but as this person quoted, it's unlikely to become widespread in the near future because of the more stringent requirements, which I'll talk about in a moment, for biosimilars than for small molecule agents. And drug companies have developed strategies that delay the release or make it as ineffective as possible, obviously to support the patented therapy. So why do we need biosimilars? Really, it's the cost of the medications that's the main driving force. And in Europe, the discounts have been set for a first biosimilar. They vary from country to country, but you can see some of the data here, 5 to 15% savings in the UK, 20 to 45% in Germany. And some other countries were getting similar discounts. In the US, biosimilars have now started to reach some 35% discount, although Medicaid is only 12%. They're supposed to be competitive, so now there's a number of different biosimilars all fighting for the same marketplace. And it's been estimated that, at least in the USA, that the use of biosimilars will hopefully reduce the direct spending on these medicines by an astronomical figure of some $54 billion over a 10-year period, or about 3% of the total biologic spending. So before I go into a discussion about the biosimilars, I think there's some jargon that's worth reviewing, and some of these terms have been used variably by different countries. The branded medication is often known as the innovator drug. It's the one that had to go through the proper testing. You've heard just from Ludwig some of the studies that were performed for the BTK inhibitors, whereas the biosimilars have also been referred to as follow-on or follow-on biologics. This is a term that's used to encompass all the generics and complex generics, so the follow-on therapies, as some of the governments refer to it. The true generic is a copy of the brand name drug, and this usually applies to a simple molecule, but it's often exactly the same. Think of ASA and how many different forms there are of that from the original branded form, but it's usually the dosage is the same, the safety has been the same, the PK/PD, route of administration, et cetera, all the same. The biologic products are a little bit different because it's an active ingredient, usually from some biological source, and that's got some issues associated with it, which I'll discuss in a moment. And a biosimilar is essentially a generic version of the biologic that I just talked about. It's also referred to as a follow-on biologic. And then there's this other entity that seems to have a definition of its own, the subsequent entry non-biologic complex drug. I did not make that up. That refers to a group of drugs called the glitterimer-like molecules, because it's not like anything else, and I'll come back to that in a moment. So the idea of these follow-on biologics or biosimilars, they're not required to be exactly identical to the reference product, but they have to be at least comparable or highly similar with no real differences between, say, safety and, more importantly, purity and potency. If we talk about equivalence, and I'll come back to that in a moment, this is a range, and how you decide something is equivalent requires actually a very detailed type of study. And how you negotiate that is usually done with the agency. So in Europe, it would be with EMEA and FDA and the United States. If you're going to develop a molecule and call it equivalent, then you have to sort of have ideas of how equivalent it is. And there's some compromise. Obviously, you're not going to go do the same highly expensive long-term studies that the innovator drug had to go through. Otherwise, there's no point in creating a biosimilar. But you have to establish that it's safe, that the safety is at least similar to the innovator, and that there's some measure of efficacy. And if you make the conditions too stringent, then nobody's going to develop a biosimilar. If you make them too relaxed, you're going to get something that may not be workable. Interchangeability is something that occurs at the level of when you take your prescription in and someone just slips in another drug for you, even though you're expecting something, they slip in something else. But that is really a stringent requirement. It's expected to produce exactly the same results. Sometimes it's done without your knowledge whatsoever, if a molecule is considered interchangeable. And that may be a designation you can give to a follow-on product. If it meets the certain requirements, then it can be substituted for the brand name product by the pharmacy, I guess. So if we're going to do trials to look at biosimilars, obviously the endpoints, some of which you've heard a lot about today, are not going to be the same. But there is some measure of efficacy and safety. And you're trying to make sure that the biosimilar has some equivalent, well, I don't want to use some equivalent type of efficacy, but no real changes in safety. And similarly, if you have a mitigation strategy, say liver safety or JC virus activation for PML, you want to have a similar strategy for the follow-on biologic as well. This other non-biologic complex drug, GA, I mean, this is a unique molecule for sure because it's not really one molecule. It's a series of amino acids that combine randomly to form a product. So there's a lot of these glutaramoid type drugs that are out there, and they're not like an ASA molecule. You get this concoction that somewhat is similar to the original. But you still have to kind of prove the equivalence to the originator, and there have been studies obviously in that regard. So let's get into the actual kinds of differences for biosimilars. There is this microheterogeneity that's actually really important. Think about these are biological structures. They have complex 3D structures that may be very relevant to the way they work in the body, and there has to be some way of measuring that the variability has to be minimal. And these post-translational modifications are very important, especially some of these glycoproteins that are put on the surface can change the way in which the drug works, but also can change the immunogenicity of the molecule, and that creates problems when you look at how the body reacts to it. And I'll come back to that in a moment because there have been some disasters that have occurred. So just look at the size of, say, a monoclonal versus the ASA or aspirin type of molecule that you could barely see on this screen here. So this is a very different type of complex structure, and one has to look at all the different ways in which it can be produced. So there are post-translational modifications, there's this higher order three-dimensional structure, there's the tendency for complex molecules like this to aggregate. That's a problem. There are these microheterogeneities that may look like they're very simple, but when you put them in a body that can induce immunogenicity. And some of these minor impurities or contaminants can also lead to side effects that are not anticipated, compared to the innovator or the original drug. And so some of those minor changes can be very key, and you have to be able to look for those, especially the immunogenicity. It's been said that animal models are really not enough, or are completely inadequate to predict how this is going to work in humans, including even the humanized mouse. This kind of variability, especially in humans, is governed by lots of things. It could be racial, it could be genetic background, it could be comorbidities, it could be other medications that often are taken, even the immune status of the individual. And so authorities require at least one major study for immunogenicity with typical pharmacokinetic and pharmacodynamic assessment of the potential biosimilar. Why? Because there was a disaster, and many of you may have known about the EPREX story. So this was the development of erythropoietin, and what happened was it induced, through some impurity, a neutralizing antibody which reacted with the body's own endogenous erythropoietin and caused very significant red cell aplasia in those individuals. And all you were trying to do, in fact, was boost the number of red blood cells using erythropoietin. The equivalence of biosimilars can be particularly challenging. Look at the studies that we've heard about today, just what goes into actually assessing the efficacy of the drug. And so you can't just do simple pharmacokinetic studies because you don't know necessarily what a level is. Think about GA, glutamate acetate. Can anybody measure a level in people after you've injected it? You can't really do that. So you can't really do a pharmacokinetic study. Other drugs have such a short half-life that by the time you go and measure it, it may be immeasurable. So what do you use? What do you use for an efficacy endpoint? Nobody's going to do a 3-year study with a biosimilar. For that matter, even a 2-year study is probably too long because of the incredible cost. So if it costs so much to develop the biosimilar, no one's going to make it. So clinical endpoints you've seen are so insensitive for even the innovator drug, it's going to be a disincentive for anyone trying to develop a biosimilar. So that really boils down to the most frequent outcome measure that we use in MS, which is imaging. And there has been some acceptance of that. Just to give you an idea of the steps that are involved in trying to develop a biosimilar. So the original drug on the top row, you can see here, and then the biosimilar on the bottom. There's usually an interest in one particular molecule. One has to do some preclinical studies. And then you do your clinical equivalent studies, and then you do your phase 3. You go phase 1, 2, 3. It's a long development program to get a drug to market today. For the biosimilars, you're trying to collect the data that you've known from the innovator drug. You do some basic studies in often animals, and then you look at some of the comparative studies and go to post-marketing. The rules are different, and this is now a very complex slide. I apologize, and you can't possibly read this? I can't even read that. Okay, but you can see the major steps that are involved. That the authorities on the left, it's the European authorities, and on the right, it's the American, the FDA, and the different steps that have to go through. So this is not a trivial process to develop a follow-on biologic by any means. There have been some consensus recommendations, and these have come from a committee. Maybe some of you in the audience or here have been part of this. This was developed by the European group, and they said this is what we expect. If we're going to see a biosimilar, we're going to use it in our clinical practice. This is what we expect from the studies that were done here. So first of all, some evidence, and this has to be a fairly rigorous analytical type of experiment where one looks at all the therapeutic targets and show for the compound that it's having the desired effect, and that this data that was generated for the follow-on biologic or disease-modifying therapy, it's good enough that it was accepted to peer-reviewed journals and everyone can refer back to that type of information and use it accordingly. that a lot of requirements here for treatment and access, right? This is an effective option for management of MS. The whole idea is to reduce the costs of the drug and improve in many parts of the world, even in Europe, improve access for patients with MS. You want to make sure that it was developed in a country, if it was done one country or many countries, that these are developed by in the process of a highly, carefully structured, regulated rules for performing clinical trials. Some equivalence trials or some development of biosimilar equivalent trials were done in places where maybe that's not so true. And so what comes out of those studies may not be as strong as those that are done under proper regulatory authority. And then if it's developed this way, switching from the reference, the innovator product, to the follow-on biologic has actually gone through a proper review, and it's got that regulatory review with all its nuances associated with it. And some of the biosimilars that are approved by EMEA and FDA that I'll show you in a moment have gone through that process now. That there's scientific and clinical evidence for switching, where you don't lose necessarily efficacy from switching to that compound. They're starting to see those. If you see that something's been developed outside of, we'll say, a highly regulated area, you might want to question whether that's a biosimilar you want to use. And we'll come back to this later, but if the pharmacy decides to switch whatever you've been prescribed for something else, that needs to be communicated to the patient. It should not be a surprise to them that they are receiving something else that they shouldn't have gotten originally. That it's not enough just to make the drug. Because of all the things that I've just told you about how they can be different, there has to be some sort of pharmacovigilance and follow-on collection of data, just as we expect of the innovator company to collect long-term data, long-term safety data. There has to be a push to do the same for the biosimilar. That's not necessarily true, and they're not doing it, but I think it's important that this be pushed. This is what these recommendations were all about. If you get this drug, it should be noted in a patient's file so you know what they've received before, because sometimes what they receive afterwards may be very different, and there's some data I'm going to show you in a little bit where the biosimilar may not have the same sort of safety record. Are we getting this long-term pharmacovigilance data? We probably aren't, but it should be. We should be collecting these in some sort of registry so we can look back and see which biosimilars have had some problems. And all these companies that develop it have to sort of be committed to improving patient care and education and collecting this data prospectively. These are very different rules from generics, right? I mean, all you have to do is make a 3D structural drug that looks exactly the same as the innovator drug, do some PK/PD, and you've got a drug on the market, and that's the end of the story. But the quality analysis, especially some of these post-translational modifications that are so important to how the drug actually works in the body, is really important. And some of those should be at least assessed using high-resolution types of technology like mass spectrometry. This has been recommended, especially to look for protein aggregates, because it's the aggregates that can be very immunogenic and then lead to the terrible EPREC story that I told you about. So that's part of the purity testing of a biosimilar that the drugs have to go through. Now, this is just a quick list of, on the left is EMEA, and on the right is the FDA, and you've got your brand name drugs down the column, and then you've got your follow-on version, and there's been several of these that have been now available, and they all have the names that you can see here. So this is not a trivial problem anymore. We're getting a lot of biosimilars becoming available. As you go down the list, there's been less interest to develop the generics for some of the S1Ps, probably just because they're not as used as much as was anticipated. So these are some of the oral agents, and then we get to the biologics. There really hasn't been a big push develop the interferons. There have been some countries that have developed these, and whether they've gone through those processes is questionable. So we don't see very many of these. You've got some now. You've got something for the GA group that's available, not in Europe so much, but in the United States there are. And then finally you get to the monoclonals, and there's now, I'll tell you about one anyways, a biosimilar to natalizumab. There's several to rituximab. There may even be one available for ocrelizumab, but not yet approved by the agencies. We're familiar with the original phase 3 trials, right? You do it against placebo, or you do it against an active comparator. The new drug shows a benefit that's quite superior, statistically significant, and this is just an example of a superiority study. You've already heard we've got the latest results for fenebrutinib, which is a non-inferiority study. So that's a different type of an idea that can look for equivalence. And that's what I'm showing you here. So you've got your innovator, your original brand name product, and you've got your biosimilar next to it. And we see equivalence. So when the numbers are exact, that's great, but that's not the way things work in nature. So you have to be able to demonstrate equivalence, and in order to do that, you negotiate with the regulator, and often in the case of, say, something like fenebrutinib, you go to the EMA, you go to FDA and say, okay, so I've got this biosimilar I'm developing or another product, and it's not, has to be, could be a little bit better, could be a little bit worse, but what are the goalposts? What are we going to accept as the goalposts here? That we're somewhere in between, and then we're going to call it equivalent. And that's negotiated. And obviously, the narrower the goalposts, the better, closer it is, but you need a huge number of patients in order to do that, and that's a disincentive to the company. So this is why it needs to be negotiated, and you can set these limits, and as long as the result is in between the goalposts, this would be an example of an equivalent. Here's another example of an equivalent. But this one is not, because it goes beyond the goalposts, one way or the other way, so you don't get equivalence in those regards. And that's the kind of study that's then being done. What are you using to test equivalence? I already suggested that the most acceptable measure is probably the MRI, especially the number of enhancing lesions, because it's easy to get small numbers of patients and show what you need to show from that. It's been accepted that these are sensitive enough to check between the biosimilar or the potential biosimilar and the innovator product, and certainly that's been accepted by EMA to look at. And there are examples of this in the literature. I'm just going to show you a few of them. So here are the glutiramoids. These are all the drugs that pretend to be similar to the original name brand glutamer acetate because it's such a unique molecule. There are so many versions of this now, and people are using GAD lesions as a primary endpoint. The original trial was called the GATE trial, so you can see here I don't know, do I do this here? How do I get the, not sure how I get a pointer on here, but anyways, you can see, oh, you're gonna show me how to do that. I gotta use that. Ah, okay. Okay, so here's the innovator product, and then you've got three arms here, right? So you can then look at your test agent, the GTR versus placebo, but you could also see the original innovator arm here and look at the results. And this is in fact what was shown here, was that the pooled result here was not inferior to the name brand product here. And in fact, some of the results of that study suggested it might have even been better. This was the predetermined goalposts for the GATE study. So you can see these were the predefined margins, and for the most part, it's in between the goalposts. Therefore, it's considered acceptable and equivalent for that purpose. We've now got a study that looks at a generic form of natalizumab. So this was called the Antelope study. It was a phase 3 study looking at this biosimilar and, in fact, looking at GAD-enhancing lesions. Really not much difference here between the biosimilar and the reference, which was the orange. but this was the negotiated goalposts. Plus or minus 2.1 lesions was chosen by the FDA. There wasn't any significant difference in the secondary efficacy outcomes in this particular trial. The other MRI parameters, even EDSS score and relapses were quite similar between the two. And there was nothing on immunogenicity either. But, and I say but, because there's always a but. Something has emerged from all this. Remember, I was telling you that there's a mitigation strategy that's put in place for natalizumab. You do the antibody test, and that puts patients at risk or not of getting PML. That test was a test that was proprietary by the original company making natalizumab. And so now you had to develop a secondary test, and is that test the same? And it turns out probably it's not. And you can see the results here in this particular study using what's called the ImmunoWell, that you've got patients here that discordant for their risk. If they were in fact testing negative on this Stratify, they were actually positive on the ImmunoWell. And so which one do you believe? And that's a problem for the risk mitigation strategy for the natalizumab. And now we've got an ocrelizumab originator. This is something that was developed in one country. We can argue whether or not that's a highly regulated country or not, but that's not for me to tell you about today. But it was a randomized two-arm study. It was published in Nature Scientific Reports. The primary outcome, not gadolinium-enhancing lesions, but ARR, a very insensitive marker, as you know today from some of the other studies. Take that with a grain of salt. But they showed that it was really not inferior based on this particular study. So this is an example of maybe one that we wouldn't want to put high on our list because there's some questions involved in that study. They said it was targeting CD20 cells. They were recognizing non-identical overlapping epitopes. There was a question of rituximab in terms of molecular composition. We know this for a while. It's always been considered a dirtier molecule. Can we substitute it? People have been using rituximab off-label for years for the treatment of MS. And the Swedish have just talked to us about a study that they can even change the interval dosing for up to about 18 months. But there's a lot of differences between these molecules. One's humanized and one's sort of more mousy. There is some theoretical differences between complement binding and ADCC toxicity, cytotoxicity versus the direct cytotoxicity. But all of this really boils down to, is there any difference in efficacy? So do we know that? Not necessarily, but there was this attempt to retrospectively look at a population in California based at UCSF versus the entire state of California to see if there were any differences since so much rituximab had been used over the years. And they collected the data from, not a small number of patients, some 1,400 patients at 6 different sites, and they looked at a few things now not beyond efficacy. They looked at maybe a safety issue here, hospitalizations and infections, and even hypogammaglobulinemia and how often that occurs, as well as confirmed disability at 24 weeks. So this was the statewide data that I'm just showing you here. And of interest, you see in the orange, is the rituximab versus blue with the ocrelizumab. So significant number more hospitalizations in these people who have taken rituximab. And when you look at some of the more specific things, you can see that there were more pneumonias, more cellulitis. There were a lot of things related to perhaps the more dirtier of the rituximab versus ocrelizumab molecule. And this is just to show you that what was seen at UCSF was typical of what was seen in the entire state of California. When you look at hypogammaglobulinemia, we're worried about it with ocrelizumab, but obviously you'd be a lot more worried about it with rituximab, and that was a much higher incidence in the patients who have been taking rituximab. So the result of that study was more all-cause hospitalizations. The hazard ratios were similar in terms of rituximab throughout the state versus just the UCSF alone. Definitely more hypogammaglobulinemia, and the overall safety profile was better for ocrelizumab than for rituximab, even though one perceives of similar efficacy. There's finally this a few little issues that one has to consider that go beyond this, and that is the patient acceptance. They need to understand, if you believe that a biosimilar is just as good as the innovator, you need to explain to them why. They are all very active on social networking, and they get this thing in their head that, oh, I'm going to get this other thing, and it's not as good, and I don't want it. And there's that famous nocebo effect. Everybody know what that is? If you think you're not getting something real, then something bad's going to happen to you, just like the placebo effect. If you think you're getting something real, maybe there's a benefit from there. We can't have pharmacies just willy-nilly giving a substitution without explaining that to patients. We also would insist that the maker of the biosimilar program put together a similar or at least equivalent patient support program similar to what we get with the brand name, and there is an attempt to do that. But we have to be aware that social media is driving a lot of these patients. So in conclusion, I think the available of generics and biosimilars are really important because they're going to push us to a level where we can maybe even consider using combinations. You have to come back Friday morning and I'll tell you about that possibility. But there's an incredible potential savings to everyone if we move to the biosimilars. The development program is different. We have to accept that. And there are some guidelines, and you saw those coming out of Europe that are governing how these generics and biosimilars are working. And then there has to be, and we have to push for this, that the people who develop the biosimilars somehow collect post-marketing data to ensure that the biosimilar is not having an adverse event compared to the innovator drug. It's all about the balance of the costs, right? Thank you very much for your attention.
Thank you, Mark. Next, we're going to have an introduction to remyelination by Professor Catherine Lubetsky from the Salpêtrière.
Yeah, it's okay. Hello, everyone. Did you hear me? Okay, thank you very much, Mark. It was great. So I would like to welcome all of you, and I imagine that you're exhausted. I hope that you still have some active neurons, you know, to follow the talk, but it will be a short course, and it will be mostly on remyelination. The course will be an introduction to remyelination in the central nervous system. And what I wanted to say, I would like to thank very warmly the organizing committee for this invitation. First, the meeting, this is the course, but the meeting, the whole meeting is very exciting. I only arrived during the afternoon, but I already learned a lot. And then we know this is a fantastic location. And then I would just like to say very, very few words, but I am very happy that the European Charcot Foundation is still going on and very well and very actively. And I would like to thank all the organizing committee, but especially Hans Peter and Javier Montalban, who have been co-leaders of the new European Charcot Foundation. But nevertheless, you are fantastic, but nevertheless, I am, and I think we all are, deeply missing Giancarlo Comi, who was a great medical physician, a great scientist, and a wonderful person. So I'm going to speak today about remyelination, and these are my disclosures, but just to make it short, none of them is related to what I'm going to say today. And this is in the next few slides, 2 slides, there is a very simplistic model of what is the pathogenesis of multiple sclerosis. I don't have a pointer, but I think you will see easily. So almost all of us think that it all begins with inflammation in the central nervous system. It's one. and then this inflammation in the brain, in the central nervous system tissue, is leading to acute tissue damage with demyelination and axonal loss. And if demyelination and axonal damage persist, then there will be irreversible axonal loss, which is well correlated, as we know now, to disability progression. So very simplistically, but I took this for a recent review, if we want to prevent disability progression, and it has been said very nicely previously by my colleague, we have either to prevent the tissue damage, and the prevention of tissue damage is mostly related to the use of more and more effective immunotherapies, and I will not detail that because it was very nicely detailed by my colleagues. But the other way, in addition to immunotherapies, is to try to promote recovery, and without entering into detail, to promote recovery, remyelination is a way to prevent recovery, and this is what I'm going to speak about. So my course will be divided in 3 parts for sake of time. I will begin by the myelin impact on axon, what it is, what is it. The second part, I will speak a little bit more in detail on the nature of the remyelinating cells in the adult central nervous system. And in the last part, I will allude, but again, without going into detail, on the emerging trials on remyelination. So let's begin with the myelin impact. I think you know most of what I'm going to say. So the myelin impact of axon is dual. One important role, which is known by all of us, I think, is the effect on the rapid conduction of the nerve impulse, what we call the saltatory conduction, and I will say a few words on that later. And the other important impact of oligodendrocyte and myelin is the metabolic support to the axon, so it provides a metabolic support for axonal integrity. So let's begin very briefly with the saltatory conduction. This schematic representation taken from Peter Brophy is showing a myelinated axon. You see on the left the cell body of the neuron, then the myelinated axon, and all the myelinated internodes are separated by a node of Ranvier. So in this conduction of the nerve impulse, the action potential is generated on the left at the axonal initial segment. And then when the axon is myelinated, the action potential is jumping from the AAS to one node of Ranvier, and then from one node of Ranvier to the other node of Ranvier, etc., etc. So this makes the increased conduction of the nerve impulse that we name saltatory conduction, saltation meaning jumping. And as we all know, I think, axon caliber is also playing an important role in the velocity of the axonal conduction. But if we take 2 axons of approximately the same caliber and we compare myelinated versus non-myelinated axon, we can say now that there is an increase in the conduction by 20 to 100-fold, so a loss between myelinated neurons and non-myelinated neurons. So I'm not going to speak of it. It has been very important for the physiology of the central nervous system, also the peripheral nervous system. It has been important also for evolution, but I'm not going to detail that. So one key impact that we all know is that myelin provides a saltatory conduction, a rapid conduction. The second impact, as I just said, is that myelin and oligodendrocyte are providing an axonal metabolic support. So on this graph, which is not very beautiful, but which has been given to me by Klaus Thavein, it is coming from one paper on the group. On the top, you can see the blood vessel in red. On the bottom, you see the axon in brown, and in the which is surrounded by the myelin sheath. And just below the blood vessel, you see in blue the oligodendrocyte, and in green the astrocyte. So if we focus on this graph, which is in fact very clear, if not beautiful, to provide metabolic support, glucose is taken from the blood vessel to the astrocyte, or indirectly or directly from the blood vessel to the oligodendrocytes through glutamate receptor, glucose receptor, and then glucose is going into a glycolytic cycle, providing the occurrence of pyruvate and lactate, and contrary to glucose, lactate is able to be transported from the oligodendrocyte to the myelin sheath and to the axon. So this metabolic support that we call a coupling between the axon and the oligodendrocyte is very important for the physiology of the axon, of course, but it is particularly important to be able to feed the long extension axon. They are very long, the cell body is very far away, so they have to be metabolized, able to provide feeding to this axon all around its tract. So saltatory conduction first, and then axonal metabolic support. And if there is either demyelination or a defect in oligodendrocyte physiology, then there will be a disruption of this coupling between the oligodendrocyte and the axon, leading to metabolic axonopathy in the CNS, but also in the PNS. So this was myelin impact on axon, and you know, as I told you, most of it. The second question, I think you know at least part of it, is the nature of the remyelinating cells in the adult central nervous system. There are many cells in the adult central nervous system. What are the cells in charge of remyelination in the adult brain and spinal cord? So for this, I will summarize decades of work. And just I want you to have clear in mind that the cells responsible for remyelination in the adult CNS can be either direct actors, and they are oligodendroglial cells, and we'll detail most of them. But in addition to this direct impact, there is also an indirect role of microglial cells to provide remyelination. So let's begin with the cells of the oligodendrocyte lineage. And as is shown here on this slide, you can see that different types of cells are able to remyelinate in the adult CNS. First of all, what we call the oligodendrocyte precursors, we call them also OPC or resident OPC or resident adult OPC. They are making new myelin sheath after a demyelinating attack. They give a thin myelin sheath, which is very typical of newly formed myelin. And those cells have been hypothesized for decades are contributing, be the most important contributor to remyelination, both from MS tissue, but also from experimental model. So first type of cell, I will say a few words later, are the OPC, the adult OPC. The second type of cells are the progenitors of oligodendrocyte located in the subventricular zone. And as you will see later, they are able to form new myelin sheath, very functional, and contrary to the previous sheet, they are leading to elaboration of thick myelin sheath. And the third type of cells, and it has been a burning debate during many years previously, are the mature oligodendrocyte, committed oligodendrocyte. Are these young oligodendrocytes newly dividing, or are they all surviving oligodendrocyte? As you will see, the cells that are the committed oligodendrocyte that are contributing to remyelination are mostly surviving oligodendrocyte. So let's go in the detail of these three types of oligodendroglial cells. So this is a schematic representation. I hope you can see. Yeah, you can see it correctly. So on this graph, I depicted in green the adult OPC. They represent up to 5% of the total brain cells, and they are disseminated in the brain, but either in the gray matter and in the white matter. And interestingly, these adult OPC have been largely ignored during years. They were ignored because we didn't have good markers. We have now many good markers. Here are some of them, the NG2, and sometimes we name this population NG2 glia, and the other marker is the alpha receptor for PDGF, platelet-derived growth factor. So with this, we are now able to quantify the number of adult OPC within the brain. And as I told you, it was thought for a year that they were mostly contributing to remyelination. This is still true, but we also know now that these cells can be detected in experimental model, in MS tissue, and also in multiple sclerosis lesions. So adult OPC, probably the main contributor. The second type of cell I wanted to allude to are the progenitors of oligodendrocytes located in the subventricular zone, SVZ. So as I told you already, these cells are interesting because they are synthesizing a thick myelin sheath, very functional, but as they are in the subventricular layer, they are mostly contributing to remyelination in the neighboring area, which means in the corpus callosum. So this is, I think, yeah. So this is again a schematic representation of the subventricular zone progenitors located, you see them in green, in the subventricular layer. And it was shown a long time ago, almost 20 years ago, by the group of Arturo Alvarez Buya, that those cells were existing in the adult central nervous system and were able to detect, as you can see in the picture of immunohistochemistry, we are able to differentiate into oligodendrocyte, myelinating oligodendrocyte, and remyelinating oligodendrocyte. So on the left-hand side, you have different views, in fact, of those progenitors of the subventricular zone. And I told you that the myelin they are synthesizing is very functional. And on the right-hand side, this is a paper from our group, and where we have used an experimental model of the myelination, and the conduction velocity has been measured by analysis of the compound action potential. And without entering into detail, what I know that you see the graph, on the right. You see that after demyelination of the corpus callosum, you have the corpus callosum in the middle picture. The compound action potential analysis is completely normalized compared to the other type of experimental paradigm. So those subventricular zone progenitors are also synthesizing myelin, thick myelin, very functional myelin at the electrophysiological level, but they only probably remyelinate corpus callosum or neighboring areas. Then the third question is this one. Are the third type of cells involved in remyelination are the committed oligodendrocytes? Are they young? Are they old? So it all began with the paper published in Nature 2019 by the group of Jonas Friesen, who has led to a lot of challenges, discussion, etc., etc. And the question raised by Jonas Friesen was to know whether in the remyelinated area, the oligodendrocytes were surviving oligodendrocytes or newly formed oligodendrocytes. And for that, he used a very elegant method of retrospective birth dating of oligodendrocytes in multiple sclerosis postmortem brain by analysis the result of the nuclear bomb test performed during the second half of the 20th century, not on the 21st century, yes, that is in Europe. And so, if you look on the left again, so the conclusion of this paper was that they were not able to see oligodendrogenesis in the remyelinated area, so they were not newly formed oligodendrocytes, and the major conclusion was that the oligodendrocytes in this adult brain of remyelinated lesions are old. So interestingly, and now you go to the right, this has been confirmed, it was 1 year before, by the group of Jan Duncan from the US, and using different types of experimental models in different species, and using electron microscopy, he was able to show and to confirm that indeed adult oligodendrocytes, so committed oligodendrocytes, are playing an important role in remyelination. And I couldn't resist to put also one very old presentation from our group where we have shown by a transplantation experimental paradigm that adult mature oligodendrocytes were able to remyelinate. So to summarize the role of oligodendroglial cells, so 3 types of cells are playing an important role in remyelination in the adult CNS: OPC, oligodendrocyte precursor cells, subventricular zone progenitors making a very functional myelin sheath, and then surviving oligodendrocyte, which were committed, but which are able, when they survive, to make new myelin sheath. So I told you already that in addition to this direct impact, there is also an indirect impact through microglia. So let's say a few words on microglia and remyelination. So what is microglia? I'm sure we all know that microglia are the resident macrophages of the central nervous system. And now that we are able to identify them using specific markers, we can say that there is up to 12% of the total CNS cells that are corresponding to microglia. Interestingly, and I think this is very important with what we heard recently with the new drugs, it's very important to have in mind that microglia can indirectly at least be involved in remyelination. It's important also to have in mind that microglia in humans, but also in the different species, is a very heterogeneous population. There are some microglia which are involved in the damage of the CNS tissue, and they are, in contrast, pro-remyelinating, pro-neuroprotective microglia. These pro-neuroprotective microglia, the mechanisms are mostly related to phagocytosis of myelin debris, and axon to be able to be remyelinated have to have no myelin debris on the surface, but also the secretion of pro-regenerative cues, growth factors and cytokine, and also the modulation of the extracellular matrix. So you see this on the right-hand side. It's almost a schematic representation, but I really advise you to go to this paper from Véronique Miron, now in Canada, showing the relation between microglia and remyelination, and emphasizing the fact that among the different factors in the different mechanisms, what is important is by microglia is the clearance of myelin debris, the secretion, the release of pro-regenerative growth factor and cytokine, and the modulation of the extracellular matrix. So just a little bit of digression on this microglia, on a new concept, on the emerging role of lipids. And the paper from the group of Klaus Nave and Jessin Saer in Göttingen in Germany has shown an important role of microglia to synthesize sterol through a post-covalent sterol pathway. And this synthesis is able to switch the phenotype of microglia from a pro-inflammatory to a pro-regenerative phenotype. And I advise you to read this paper, last author being Jessin Saer, and which shows very nicely that microglia indeed facilitate repair of demyelinated lesion via post-covalent sterol synthesis. And then finally, to make a very, very long story short, and without going into any detail, this is a summarized slide on the role of microglia and on the role of neuronal activity. So as I have no pointer, so you look on the right, and we were able, and it was mostly the work of Clément Perrault, we were able either by using optogenetic or DREADS methodology to increase neuronal activity. So this is the arrow on the right. And this increase in neuronal activity in vitro and in vivo has been able to switch the microglia from a pro-inflammatory phenotype that you see in pale pink to a pro-remyelinating phenotype that you see in pale green. And this pro-remyelinating microglia is enabled indirectly to stimulate oligodendrocyte in green, and oligodendrocyte will perform the new myelin sheath. So this is also very important, and I think that if we think of therapeutic strategy, we have that in mind, to know that there is an activity-dependent regulation of the microglia phenotype. We analyze that by RNA sequencing, and that this might be an alternative way for remyelination, of course, in addition to an immunotherapeutic treatment. So last part, very briefly, because I'm not going to go into detail on the emerging trials of remyelination. What I want you to have in mind is that there are many trials, but if you look on the left-hand side, you can see that these are mostly, if not only, phase 2 trials. So on the top, in orange or red, are completed study, but phase 2 only, and on the bottom, in blue, the ongoing study. And if you look, you can see few words in bold, but not many. One of them is, for example, corresponding to the GSK product on the top, the second one, which is positive, but the effect is very, very small. Then there is also the study by opicinumab, which was partially positive, but only on the per-protocol population, not on the intention to treat. And then the study published in 2017 by Harry Green on clemastine in a very small population of patients having a chronic optic neuritis, and they showed positive result. It was a crossover study, but again, the population was very small. Concerning the ongoing study, no bold or very little bold, in fact, except the study that we heard recently at the last ECTRIMS meeting in Barcelona on the association of clemastine and metformin in patients with relapsing multiple sclerosis. So I was telling you previously that it's important to have in mind the role of electrical activity. Where are we concerning the role of electrical activity? We are not very far, in fact. There are some general strategies like the DBS or the RTMS. The DBS is used mostly for Parkinson's disease and very effective. But to my knowledge, I think, concerning in MS, it is only exploratory because there has not been large study focused on multiple sclerosis patients. And of course, DBS is an invasive strategy. RTMS is non-invasive, so this is good, but it has also to be considered as inflammatory because it has been used in different types of disease, but no study focused on multiple sclerosis. And finally, but I'm not going to detail it today, we have a study which was a phase 3 study, short study only, small study only, that we name OnSTEAM and that we perform in the Paris Brain Institute in patients with MS and acute optic neuritis. And the result, I will speak of it later, can be considered, I think, as partially positive, but I will speak more. So before closing this course, I just would like to let you with some additional thoughts. So as we have seen, you look on the left, as you have seen, there are rather many studies on pro-remyelination, but only few promising results, and mostly phase 2 study, except our little study, which was a phase 3, but a small study. So we have to think, and I advise you to think of it and to try to find new answers, Why are there so many phase 2 failure for pro-remyelinating drugs or strategy? Is it because we don't have the right target? We have been mostly focusing to date on oligodendroglial cells. Maybe we have more to think about the possibility to increase remyelination using microglia, and maybe the BTK inhibitors would be an important strategy to develop. Is it because it is not the right population? And I'm not going to detail on the difference between relapsing MS and progressive MS. Is it because we don't have the right marker? And here, the answer is yes, we don't have the right marker. We have, and it's good to quantify demyelination and remyelination and do a quantitative analysis to have the PET study, which is very good, and the ligand is specific to myelin. Can be also specific for activated innate immune cells. But PET scan, to our knowledge, I think, is not yet very suitable for multicentric study, which is a problem. And then we heard of it, and maybe we'll hear of it later also, on the role of aging in experimental models, but also in MS. Most of the studies have been done on young patients, which means patients below 45 years of age. And this certainly has to be taken into disease because as we age, we don't remyelinate as well. So we have to keep the role of aging when devising a new design for pro-remyelinating strategy. So on the right, so the young patient, I said it already. And then I just want to allude also to the fact that in many studies, and if you see on the list, which is not exhaustive, in many of these studies, in fact, the included patients were patients with either acute or chronic optic neuritis in the context of multiple sclerosis. So it's easy because we have a nice outcome measure, which is the latency of the visual evoked potential. We are developing others also. But is optic neuritis the same as the whole brain and spinal cord? I'm not sure. And in addition to that, and to going back to electrical stimulation, neuronal activity, should we add to druggable strategy, should we add exercise, which is a way of also to stimulate neuronal activity? But nevertheless, and altogether, we have to keep in mind the fact that despite there are many failures, there are many studies ongoing, and the important thing also, because we need them, of course, there are several startups which are currently focusing on remyelination therapy. So these are my key conclusions, and then I will stop. Promoting remyelination via oligodendroglial, but also via microglial target is sound. We need more studies, more phase 3 study, and we need, of course, larger study. And concerning simulation of neuronal activity, that is very close to what I'm doing at the moment, it really can be considered, even if we need more studies, as a new perspective for remyelination. And with that, I will stop, and I will thank you very much for your attention.
Thank you, Catherine. So our last talk of the day will be from Professor Daniel Antonato from the Mellon Center at the Cleveland Clinic, who's going to discuss symptomatic therapies.
All right. Thank you so much, Fred, for the really kind introduction. And thank you so much, Catherine, for such a fascinating talk. I have a tall order. We heard an exciting talk about remyelination, and now I'm going to talk about something slightly more mundane, which is multiple sclerosis symptom management, and it's the very end of the day, so an applause for everybody who's still here. Thanks for staying. So I've been giving this talk several years now for academic CME, and I think this talk always looks to strike a balance between, recommendations that somewhat review evidence, but also are very easy to interpret and easy to apply in clinical practice. These are my disclosures. I would just highlight the last bullet point there, as many of these slides are actually taken, stolen, gifted by two people, Jeffrey Cohen and Stephen Krieger, and I've adapted some of these. But those are people who I think do a particularly good job talking about symptom management. So treatment of multiple sclerosis, no news to anybody in the audience today, in my mind, has three main pillars. One is disease-modifying medications. The other one is treatment of relapses. And then finally, symptomatic management. And I feel like in meetings, we spend probably the majority of our time talking about disease-modifying medications. And I would say there's not as much emphasis on treatment of relapses, which is natural because we can abrogate these quite easily with our anti-inflammatory medications. But symptom management is common and is something that we probably don't talk enough about. And I think I wanted to start out by stating some general principles of symptomatic care, and these can guide how you treat patients symptomatically going forward. One, to state that it's of course an important and ongoing aspect of multiple sclerosis care, that troublesome symptoms from MS patients need to be inquired about. So many times people will not bring up these symptoms if you don't ask about them. And you always have to look for contributing factors to eliminate. I think that is kind of one of the key pillars of doing good symptomatic treatment. In terms of kind of when we're thinking about things to actually do proactively, I think it's important to try to keep things simple. Prioritize the symptoms that are most bothersome to the individual person. Use monotherapy if possible, that is one treatment. But when you use that monotherapy, many times these medications can address more than one symptom at a time. Rational use of medication, I think, is important here. And unless symptom control is urgent, one general recommendation is starting low with whatever you do and going slow. Many of our medications have side effects, and you don't want to get yourself producing more side effects than actual benefit. And just remember that the ultimate goal here is to improve overall quality of life and function, not just to alleviate exam findings. Many times when we approach symptom care, we're trying to treat something we see on the exam, but remember that thinking about how it makes the patient feel is important. So what symptoms need to be addressed? This is a somewhat old slide, published in 1984. It was a survey of people with MS and the symptoms that were most likely to affect their ADL. And I was recently involved in the FDA patient-led advisory for new therapeutic management that Tim Coetzee presented on this morning in the PROMS initiative. And they actually sent surveys out to approximately 2,000 patients, or received responses from about 2,000 patients. And these numbers that you see here, this rank order, was basically the same. So I think despite all the advances we've made, what I reflected is that what an MS patient looks like in the clinic is actually quite similar to what it looked like back in 1984. Most common symptoms being fatigue, balance, weakness, bladder, and spasticity. Those are probably the ones that hit the most. But I think it's important also to remember the hidden or silent symptoms of MS, and these have to be inquired about, because if you don't, of course, many times you're going to miss them. And just remember that stuff like anxiety, depression, sleep disorders are far too common and can also worsen coexisting symptoms of multiple sclerosis. And I think we talked a little bit about how do we measure the patient feel function. And many times we do these with surveys, and some of these outcome measures are validated patient-reported outcome measures. At the Cleveland Clinic, we use a measure called NeuroQoL, which is part of the NIH toolbox, which covers 3 domains. And just remember that if you are using these, actually feeding back the information to the patient about what these patient-reported outcomes show actually makes the patient use them more, and their satisfaction overall increases. That is, if they're asking me about my symptoms, hopefully they're addressing them at the same time. But let's not forget next generation tools to measure MS, because what we have historically done is ask people about their symptoms and examine them, but nowadays we have a variety of different methods we can use. Experience sampling, cognition, testing of hand and arm function, testing of gait and posture, and then of course one of the big promises for the future is passive monitoring. So what we use, for example, when we use our cell phones or when we use a computer, they can track our eyes, they can track the time in between each keystroke, and these measures actually can be used to interrogate function as well. And the question is, who is in charge of symptomatic care? And that's a complex question, but this is definitely something that is interdisciplinary, it's team-based, and it's multifaceted. I think I stress it cannot only be a neurologist here, you have to work in a team. Medical care, of course, will be provided by physicians and advanced practice clinicians, but rehabilitation specialists, physiatrists, mid-level providers, occupational and physical therapists, health psychology and psychiatry, neuropsychology, social work, and then collaboration with other services, including urology. Access to care is really important here in ensuring that a patient has, for example, in the United States, we talk about insurance coverage, or in other places you might think about an individual who might not have a geographical barrier actually to get to multidisciplinary care. And I think education is important so that individuals with MS know that these things are at their disposal. And it's also important to educate families, but of course healthcare providers, the people around us, and also our trainees. So I'm going to go one by one by the, tackling some of the most common symptoms in multiple sclerosis and how we address them. And the first one, most common symptom, and the most disabling symptoms, many studies have shown, is fatigue. And fatigue can be produced by several different mechanisms. One, of course, is deconditioning. The other one is a concept known as handicap fatigue, which means that an individual with a fixed neurological deficit needs increased effort to perform routine tasks, and therefore they probably become fatigued in a shorter order. Then we also think about more neurophysiologic fatigue, and that includes motor fatigue, which is a decrement in motor performance with sustained effort, which we see. Heat intolerance, which includes worsening symptoms with increased body temperature, likely because of decreased modification of electrical impulses as temperature increases in demyelinated axons. And then rate or temperature dependent conduction failure, which can occur as well. And this might be combined with abnormal temperature regulation in people with MS, and therefore they will be warmer. And fatigue is somewhat related to neuroplasticity, and we think about this analogous to post-polio symptoms, where there's a specific threshold at which there's failure of the compensatory mechanisms that we might have. And then systemic fatigue, which is this persistent lassitude, and this we many times see when there is ongoing active inflammation, and perhaps this might also be related to soluble immune mediators. I think we've all seen patients who've had recently a relapse, and they have this general sense of asthenia. There are, of course, various validated measures with which we can measure fatigue. The Modified Fatigue Impact Scale is probably the one that's been used the most, but Fatigue Severity Scale and the Neurological Fatigue Index. Interestingly, CPATH is now trying to qualify a PROMIS fatigue measure, and all of these capture a slightly different version of fatigue, but the key message here is use one of them and use it consistently, and also to monitor treatment response. The first thing is to rule out and address contributors, ensure that there's no concomitant issues that may be optimizing before considering fatigue MS related, so is make sure that there's nothing else that's going on, specifically sleep, depression, and then of course metabolic abnormalities. I think it's important to think about heat management. So heat-related increase in symptoms generally are self-limiting, but they can be disruptive and affect quality of life. Remember, patients should limit activities in hot environments, not because it hurts their central nervous system, but because it makes them feel uncomfortable. And of course, there's various barrier methods that can decrease the temperature of an individual, which helps. And this is contraposed against multiple trials. Here I state 45 trials studying 69 exercise interventions that clearly demonstrate the benefit of exercise in multiple sclerosis. So I think it's a balance of telling individuals that they have to exercise because this will maintain their neurological function, but they have to do it in a way that, of course, will not increase their symptoms. In terms of medication management, I'm going to touch a little bit on medications that we use commonly, such as amantadine. This medication has been shown to be effective in randomized double-blind placebo-controlled trials. It's an antiviral dopamine agonist medication that also has anti-glutamate properties. And I would say that about a third of patients with mild to moderate fatigue report significant short-term improvement in this medication. The dosage is a BID dosage, and sometimes we use drug holidays if patients know that the medication has worn off in terms of its effects. And then in terms of side effects, one of the things that I always remind trainees is levodopa reticularis, which is something that can be irreversible if medication is not discontinued. Next medications that I use in order are the stimulant type medications. Approved indications for these medications include narcolepsy and excessive daytime sleepiness, but we use these medications also for MS fatigue. Medications that we use are modafinil and armodafinil. These medications do have a side effect profile which is a little harder to control: headache, nausea, anorexia, constipation, palpitations, hypertension, and carryover insomnia, which can be really detrimental to people. So this is not the medication that I reach to first. There are, of course, adverse reactions, which are typical of these. And I would say that many patients prefer the acute effects of a medication like modafinil, and others prefer the more gradual, sustained effects of armodafinil. So somewhat of it is a balance, and of course a medication holiday can also be used for that medication. And then finally, a pure stimulant medication such as methylphenidate, which is approved for ADHD and narcolepsy. This medication can be used in immediate release forms or extended release forms. It is a DEA Schedule II that is, has increased regulatory control over it, and very similar side effect profile, but a little bit worse compared to the atypical stimulants: nervousness, irritability, insomnia, anorexia. And then adverse reactions can be a little bit more severe: psychosis, mania, aggressive behavior. And so how do these medications stack up to each other? And I think these have been trials that I think have been somewhat disappointing. This study was called Triumphant MS, but is anything but a triumph. A randomized double-blind crossover 4-sequence multi-center trial, and it involved 141 patients who had EDSSs below 7.0 and MSIFs above 33. It was treatment for 6 weeks, separated by 2-week washouts of amantadine, modafinil, methylphenidate, and placebo. And after this very complicated and long, expensive study, there was no benefit on the primary outcome, which is MFIS, or any of the secondary outcomes. Amantadine, modafinil, and methylphenidate were not superior to placebo in improving MS-related fatigue and caused more frequent adverse events. So somewhat concerning. We use these medications anyway because they're symptomatic options. A second study called Combo MS. This was a study that was funded by the Patient-Centered Outcomes Research Institute, conducted by Tiffany Braley and reported out in 2024. This is a study that looked at 3 arms to address fatigue. One was cognitive behavioral therapy, 103 patients, 107 patients were treated with modafinil, and 102 actually used combination. You can see the 3 treatment arms overlap each other very closely. And I think the main take-home message here is that sleep hygiene was an effect modifier. That is, individuals who do CBT who did not have good sleep hygiene were the ones who had somewhat of a better response, highlighting that education might be as important as medication management in these individuals. I'm talking about spasticity management. Spasticity is a common symptom in individuals with MS. These older studies indicate prevalence anywhere between 70 and 85%. Interestingly, a study in 2015 also had 85%. And the goal of treatment of spasticity is to improve mobility, but also improve sleep, decrease pain, and facilitate hygiene. It's important to measure spasticity using the Ashworth scale. Otherwise, it's hard to know what you're treating and how to monitor that treatment. So a general recommendation for that. And the general approaches to this is prompt referral to physical therapy, because you want these patients to stretch. Remove other concomitant medical issues that may increase tone. When stretching is PT directed, it's much more effective, and you can target very specific muscles group. And it also has some beneficial effects in gait stability, but you also have to remember that sometimes spasticity is an assistance for walking as well. Exhaust non-pharmacological approaches first, given the side effects of the medications, which include weakness. And if pharmacological therapies are needed, monotherapy, of course, is desirable. Small dose adjustments and making sure that the timing of dosing is important. And then finally, there's our surgical and interventional outcomes. Medications that we typically use for this, probably the one that we use the most, is baclofen, a GABA B agonist. Recommendation here to start low, 5 to 10 milligrams BID, TID, and it can be up titrated up to 30 to 80 milligrams a day, but has to be done so slowly. This medication has relatively low CNS penetrance, so you have to use relatively high doses, and the main side effects, of course, are somnolence and fatigue, and of course, PM dosing might be helpful. For the individuals that don't respond to baclofen as a monotherapy, typically we either add or replace with tizanidine, which is an alpha-2 adrenergic agonist. Same recommendations, start low and titrate up slowly. Side effect here profile is a little bit different. Not as much weakness, but a lot of dry mouth, sedation, dizziness, and orthostatic hypotension. It's important to monitor complete blood counts and liver function tests on this medication. And it may accentuate weakness and ataxia less than baclofen, which is its advantage, but it also can help with back pain, headache, RSD, and neuropathic pain. Finally, other medications that we use kind of intermittently, benzodiazepines are powerful muscle relaxants, so they can be used in targeted populations. Gabapentin can be combined in higher doses, can be effective as a muscle relaxant and as a medication for pain. And then, of course, dantrolene is a medication that we use less often but can be used. Cannabinoids, I am not going to speak extensively about because they are not currently approved in the United States, but I know that, of course, in Europe, cannabinoids are a mainstay of treatment for spasticity. Talking about interventions, I think these should be referred to early on because there are interventions that have very little side effects, and specifically Botox, which blocks acetylcholine release presynaptically, has very little systemic side effects, so it's a desirable medication to use, and you can target very specific muscle groups. The con, of course, is you have to repeat treatment every 3 months. It's difficult to get approval for these, but it can be done by neurologists or physical medicine and rehab. Then if you're at a high dose of baclofen, an individual who has substantial spasticity, who also has some difficulty with walking already, one option is to use intrathecal baclofen. You use minuscule doses compared to what you'd use orally, and therefore the side effect of sedation is relieved here. And of course, it does require a test injection and a surgical procedure for these, but many times placement of these baclofen pumps is somewhat life-changing for individuals who have difficulty, especially with the daily care activities associated with severe spasticity. Infection can occur as a side effect, so you have to be careful if you're doing a procedure like this and they're using a disease-modifying therapy that might target inflammation. I'm talking about bladder dysfunction as one of the other treatments, one of the other symptom groups that is very, very common in MS. Remember that this comes in different varieties or flavors: impaired storage, detrusor hyperreflexia, commonly known as a spastic or overactive bladder. Individuals can also have impaired emptying, and that ranges from true hesitancy to actual retention. And then this can develop, of course, to a flaccid or detrusor hyporeflexia. There can also be outlet obstruction due to spasticity, and most commonly these are typically combined, making management quite difficult. These all have different neuroanatomical correlates, and it's worth remembering that. And I think here one of the things that we talk about commonly with patients is that actually doing an evaluation with a urologist who actually tests this bladder function is probably the best way of addressing these symptoms in a rational way. You start with easy things: scheduled voiding, distraction techniques, Kegel exercise, avoiding irritants such as citrus, spicy food, diuretics, coffee, what we've been drinking all day here today at the meeting. Fluid management, restriction of liquids during the night. DDAVP can also be used to that effect. Management of concomitant constipation is important. Weight loss and smoking cessation can all be helpful. If those are not effective, then if the bladder is predominantly hyperactive, of course, anticholinergics can help. A variety of different medications, oxybutynin probably the one that we use the most. If impaired emptying is a problem, then of course intravesical pressure can be used, but of course also cholinergic agents such as bethanacol, catheterization, and urinary diversion for those more severe cases. And finally, for outlet obstruction, then we use alpha-adrenergic medications, or you can also use intermittent catheterization, or finally diversion. Other interventions, the same way we use Botox for spasticity, we can also use intradetrusor Botox, and the same way that we perhaps do neuromodulation to foment remyelination, we can also use it for sacral neuromodulation and relief of bladder symptoms. I just wanted to briefly cover here other symptom mobility issues, of course, rehabilitation, and then pharmacological management of mobility issues, including 4-aminopyridine and dalfampridine. Remember, depression and mood disorders, psychology is really important, CBT and pharmacological agents. Pseudobulbar atrophy is common and can be treated with dextromethorphan and quinidine, which is an approved medication. And then for pain, I think it's important to get psychology involved and to have some type of a chronic pain medication management, tricyclic antidepressants, SSRIs, SNRIs, anticonvulsants. We have kind of as a stated rule that narcotics should not be used for MS-related pain. It does not help, and it chronicifies and intensifies pain over time. And then, of course, for cognitive dysfunction, recommendation for cognitive rehabilitation. So in conclusions, assess these symptoms at every visit, embrace a multidisciplinary approach, prioritize the most bothersome symptoms and address 1 or 2 symptoms max at a time. Have a system and approach to each symptomatic issue in MS and practice that. Prioritize interventions that affect more than one symptoms. Monitor effectiveness of treatment. Always try non-pharmacological approaches first. And then finally, avoid polypharmacy and avoid narcotics at all costs. And with that, I will finish, and thank you for your attention.
Thank you, Daniel. Well, we made it. It's been a long day. Our goal was to try and set the stage for the rest of the meeting for the ECF Symposium on Emerging Therapies. What we've tried to do is go through pathophysiology, diagnosis, disease course, onto available therapies, including remyelination and symptomatic therapies and such. I think that will serve as a decent setting of the stage for the meeting to come, which we're anticipating greatly. So my thanks to ECF for allowing us to join your program. My thanks to the faculty for the outstanding job they did, and of course to the academic CME people for their administration and organization of this program, and Sanofi for their support. So I hope you all will enjoy the next couple of days of the meeting, and now we can go off to dinner. Thank you all.